of up to 230 millimeters in length, and with a reference diameter ranging from 4 to 7.5. And for the iliac arteries, it is approved up to 80 in length and 4 to 12 in diameter. And it is also approved for the venous anastomotic site stenosis or occlusion in the AV grafts. When we use this product, there are a few things which we should keep in mind. There are certain things where we cannot use this product or should be contraindicated. The first one is when you have a lesion which is heavily calcified and is very non-compliant, and most of the times, if you cannot pass a balloon and you cannot have a good pre-dilatation, that's the time to kind of back off trying to put a stent. Because once you put a stent in there and you can't expand the stent fully, you are basically setting up yourself for stent thrombosis. And the second one is known hypersensitivity to heparin. And especially patients with HIT2, not HIT1 really, but HIT2 is a syndrome where we have to keep in mind. And the amount of heparin which is bonded on the wire band is about 400 units, which is much less than what we give. But we all know that even a small exposure of heparin, well, in a patient who has been exposed to HIT2 can be catastrophic. Well, how was the wire band developed? This is the timeline. If you see, when the wire band was first approved in Europe, it was called the Hemoband. Subsequently, after 6 years, came to the US. This is the typical time delay we have using a product from Europe to USA. And then in 2005, the wire band stent was basically approved for SFA indication. And at the time, well, the size was 6 to 8 millimeter in size. Subsequently, in 2007, the wire band was developed into a second generation wire band with heparin bonding wire band, which was developed subsequently. And in 2008, it was approved for iliac artery stenting, and subsequently in 2009, it was approved for the contoured edge. Well, the leap happened in 2011 when the wire band stent size became 1 French smaller, and most of the sizes are 6 French compatible right now. And in just last year, it was approved for revision of the AV fistulas and the AV grafts, especially at the venous anastomotic site, and these wire band stents can be placed across the elbow. As this device continued, this is basically a magnified picture of the wire band. This has an ultra-thin membrane of a PTFE, which is bonded with a nitinol support system, and it is a very strong, durable bonding film. And the edges on the proximal end are contoured. They are basically laser cut, and we'll be talking about why are they laser cut and what is the clinical significance. The inner surface of the wire band is bonded with a special bioactive surface, which is used for the heparin bonding, which can decrease its thrombogenicity. The contoured edge basically is a precision laser trimming technology and was made in 2009 when this change happened, and the excess graft material was removed, especially this contoured edge was removed from the proximal end. What was the need for this? Well, the need for this is this. Here, if you see, whenever we place the wire band, we all used to complain that, well, we have a problem with the wire band. You're having proximal edge and distal edge restenosis. So what they did was to kind of trim the proximal edge, decrease the amount of fabric so that it can improve the flow dynamics, and we can decrease the incidence of instant stenosis at the edges. If you see the proximal edge basically was about 50%, distal edge was only 6%, and proximal and distal were about 30%. So that's why, well, they made the modification only in the proximal end and not the distal end. Well, the second generation wire band came up, and they also had to make a change. Well, the change was triggered from the data from the surgical literature, which said that there was significant improvement in the patency rates when the heparin bonding was done in the vascular grafts for the FEMPOP. So there was a company in Sweden called Carmida, which had a special technology where they could bond the heparin to the inner surface of the Viabahn, and it caused sustained bioactivity and also basically made the surface thromboresistant. Inside the microstructure, you would see that the heparin molecule is bound to a heparin bioactive site and is basically linked to the endoprosthesis. Now, the question is, how long would this heparin last on the Viabahn? It generally takes about 12 weeks for the Viabahn to be bonded, and it is anchored to the endoprosthesis, and the bonded Viabahn does not elute. It basically sticks in the lumen, and it will provide sustained thromboresistance, and this occurs up to 12 weeks. If you see, this is a canine model, and this is here to check the level of the heparin bonding within the canine model. Now, another pitfall of nitinol stenting, well, the bare nitinol stenting was stent fractures. We all have seen that time and time again. Longer the stent, higher the chance of stent fractures. Now, if you have a nitinol stent which is more than 16 centimeters in length, well, the incidence of stent fracture is almost 1/3, up to 37%. And once you have a stent fracture, within the segment of stent fracture, well, the chance of restenosis is as high as 83%. Now, if you remember the Sirocco trial, which was a trial using the drug-eluting stents, they had a 27% instant stenosis and stent fracture. So basically, well, the idea of the stent was lost because of the instant stenosis. And stent fracture is rarely seen in the Viabahn stents and basically hardly seen ever. Now, why do the stents fracture in the superficial femoral artery? Superficial femoral artery, number one, is the most arteriosclerotic vessel in the whole body, number one. Number two, this is the vessel which is basically suffering a lot of stress and strain because of the muscle contraction, and also at the joint of the knee, behind the knee, there is significant amount of stress which can happen. Longer the stent, here you can see a diagram, longer the stent, higher the stress within the artery. And you have vessel shortening, which can happen in the proximal and the distal end.
Testing, 1, 2,
But if you
3.
see how the Viabahn is configured,
Testing, 1, 2, 3.
it is very flexible. It can be twisted, turned, and it is rather resistant to longitudinal compression, which generally happens in the superficial femoral artery. Viabahn can withstand all that. Now, another scourge of stenting in the SFA is restenosis and neointimal hyperplasia. If you see that if you put a nitinol stent, you have the barriers, and there is significant amount of stent growth which can happen within the nitinol stent and cause instant stenosis. What does the Viabahn do? Well, it causes a mechanical barrier and basically takes the equation out of stent restenosis from the Viabahn. And the pore size provides a barrier for tissue ingrowth. Basically, you are doing a complete endovascular bypass. So if you see this is a diffusely diseased vessel, and you put in a Viabahn, this is completely, it is completely covered, and you will not have any incidence of restenosis. It can also be placed at joints. If you see, this can be placed across the elbow, and also behind the knee, it can be placed safely. So since we are thinking of doing a long endovascular bypass, we need to go longer. That is why last year the 25-centimeter length was approved for the superficial femoral artery. Well, it cuts down the need for having a joint trying to overlap the stents, which is obviously not ideal, and also we can also use one simple device which can cover a very long length of the lesion. Now let's shift gears and talk about 3 studies which regarding the Viabahn, and this is the data which we will talk about. The first study was the Viper study. Second study would be the YSTAR. It's a European study, and the third study, which I will talk about, is the 25-centimeter Gore Viabahn study. That's the study which led to the approval of the 25-centimeter stent. Also, just to mention the Reline study and the third generation Viabahn stent, which is which will be tried. I'm just going to tell you this for informational purposes. It is called the Tigris stent, which is a nitinol frame, and it is connected with the PTFE fiber across that stent. And this stent will be trialed with a 2-to-1 randomization with the live stent in the future. Now, the Gore-Viper study was a single-arm, prospective, multi-center study. There was no control in this study. It was just simple, straightforward. You put the stent and see what happens. So it was 12 sites, 119 limbs were studied, and the primary patency was explained by the peak systolic velocity ratio of less than 2.5, and it was assessed by the independent core lab for the vessel sizing. Next point is the average length of the lesion was 19 centimeters. Well, this was a big leap from all the previous studies from the nitinol stents. If you see the smart stent study, well, the stroll study, average length was 7 centimeters. Live stent study, resilience study, was 13 centimeters. But this study almost had about 19 to 20 centimeter as a vessel length, which is rather long. And the other point to remember here is that we are talking about very complex lesions. We are talking about chronic total occlusions. More than half of these were CTOs. And then most of these patients were task 2, C, and D classification, which augurs that these are long, complex lesions. And 61% of these lesions had moderate amount of calcification in them. So from the Viper study, there were 3 points which basically came out. Device sizing. Initially, we had the concept, bigger the better. Well, not so. What we found out that if you have a stent and you do an upsizing of the stent, it really had a bad patency rate. Why? Because probably there was chronic irritation at the junction of the healthy tissue and the Viabahn stent. So they said that try to appropriately size the Viabahn, just less than 20% of the vessel size. You should not go more than 20% of the vessel size. If you see on this graph here, this is a good sizing, 1-to-1 sizing, less than 20%, and there's a significant drop in the patency rate up to 70% on 1-to-1 sizing. And also the device diameter, 5, 6, and 7 millimeter grafts had the same patency rates. There was no drop in the patency rates with using the smaller size of 5 millimeter. And lesion length was also not a factor for in-stent stenosis or stent failure. Just want to go back and highlight this point. In the Viper study, we found that in 1 year, we achieved 73% primary patency rate. That was probably one of the highest ever received in the SFA stenting. And the secondary patency rate after about 1 or 2 touch-up procedures was almost up to 92%. So the Viabahn patency rates in lesion lengths more than 20 and less than 20, there was no difference. So be fearless when you want to stent. You can go longer. So what we learned from the Viabahn stent study, from the Viper study, that the newer design of the heparin bonding and the contoured edge improved the 1-year patency rates up to 72% from the 53% rate which was seen in the Vibrant study. If you recall, that was the early study with the old stent. We only found there was 1-year patency rates was 53%. And in the Vibrant study, we also found that the 5 millimeter graft was basically not doing very well, and there was a higher failure rates. But with the new design, we found that the 5, 6, and 7 millimeter grafts have the same patency rates. Length and the number of distal vessel runoff is also not a question. You can have 1, 2, or 3 vessel runoff, and they would have the same patency rates. And obviously, appropriate sizing, don't oversize the Viabahns. That's a very important point which came out from the Viper trial. The second trial was the pretty important trial. It was done in Europe. It was a randomized trial. It was basically a trial which compared the Viabahn stent with the nitinol, bare nitinol stents. And the objective was to go even longer. In this trial, we found that the average length of the lesion, the mean length was basically 10 to 35 centimeters. This is almost like doing a complete endovascular bypass. And the patency rates were followed up to 12 months with the peak systolic velocity ratio of more than 2.5 was deemed as a failure. And the secondary endpoint was TVR and TLR in 1 to 2 years. And the stents which were compared were the whole gamut of the whole gamut of stents, which were the Bard Life Stent, Prodigy Stent from Covidien, and the Cordis Smart Control. Here's the data. 66 Viaband limbs and 63 bare nitinol limbs. Mean lesion length in the Viaband was 19, 17.3 in the BMS. CTOs slightly higher in the Viaband, almost up to 80% compared to 70%. And task D lesions, 72% in the Viaband group compared to 55% in the BMS group. Primary patency rate, 78 versus 54. Next point, lesions more than 20 centimeters, 73 versus a dismal 33. So here it shows that in the Y-star study, we found out that longer the lesion, well, the better the Viaband performs, and worse the bare nitinol stent performs. So this is the summary. Here we found out, again, just to recapitulate, 1-year patency rate, 78, 54, and longer the lesion, 73 and 33. So we had to get an approval for the 25 centimeter Viaband stent, because here we are challenging our lengths going up to even longer. So the 25 centimeter stent study was done. Basically, it was a study which was a single-arm, multi-center clinical trial. Basically, it looked at lifestyle claudication or rest pain. You picked up patients with Rutherford 2 to 4, and then you studied them. Look at the lesion lengths, 20 centimeters. Minimum, you had to have a long lesion before you enrolled in this study, 20 to 45 centimeter lesion length. Who were the patients who we picked up? They were de novo lesions, post-PTA, post-atherectomy, or occlusion of the native superficial femoral artery. So there was a whole gamut of patients, the complete spectrum. What was required in the study was the origin of the SFA. You had to have 1 centimeter coverage. You had to have a nub of at least 1 centimeter. And above the knee joint, you had to have 1 centimeter of the popliteal artery. So these were the 2 requirements. And you had to have angiographically patent at least 1 tibial vessel below the knee to qualify for this study. So this is a typical case for a 25 centimeter study. You see, look at the SFA just hanging with a thread, with a small nub, and look at the popliteal artery. And this was completely was covered with the long Viaband stent. It is basically doing a true endovascular bypass. So what was the study here? It showed that basically this is a clinical history of the patients. 76% smokers, not surprising. 1/3 were diabetics. 1/3 had CAD. And the mean ABI in this group was 0.48. Remember, this was a study for claudication. Well, this study was not for wound healing. So we were following the ABIs of 0.48. And if you see the Rutherford classification, most of them, about 85% of them, were class 3 and class 4 Rutherford. After 30-day follow-up, Rutherford 0, 39, 78%. So all the patients who were lingering in the Rutherford class 3 and 4 were pushed back to category 0. And the ABI, which was followed up, was 0.48, 0.5 mean, increased to 0.9 after 30-day revascularization. So what did we learn from these trials? So here are the summary of the 3 trials, and we added a data for a single study. Here, just to focus on the results, 312 limbs were studied, and lesion length of 20 centimeters. CTOs were 72% were CTO. These were chronic total occlusions. These were the lesions which generally go to the surgeons, and the primary patency rate was achieved at 73%. However, with a bit of touch-up, again, you can achieve the secondary patency rate of 92%. What is the gold standard for treatment of PAD of the superficial femoral artery? We all would say it's a FEMPOP. So let's see what is the data says. The FEMPOP data says, well, the bypass, 1-year patency rate in the bypass is 76%, Viaband is 72%. You go up all the way to 4 years, 58 versus 59. There's nothing to choose from. Whereas the secondary patency rates, 1 year, 83, 86, and even in 4 years, that's the same patency rates. So basically, well, the Viabahn, with a bit of care, has been able to match the gold standard of treatment for Class D, Class 4, Class D and Class C and D patients for surgery. Another important fact which has been mentioned before, that this is the length of the lesion. Longer you go, and this is the patency rates in the Viabahn stents unchanged. Well, the length of 5 centimeter will have the same patency rate of a length of 30 centimeter lesion, whereas the bare nitinol stents will drop sharply. Well, as the length goes more than 10 centimeters, there is a significant decline in the patency rates with the bare nitinol stents. So much is talked about the radial strength of these of the vessel. Whenever we have a new stent in our hands, first thing we kind of check it out. What's the radial strength? Well, what does the data say about the radial strength? 61% of the lesions had moderate to severe calcification in the Viper trial, and the patency rate at 1 year was 84%. Pretty darn good. So it was found that calcium was not an independent risk factor for restenosis or stent failure. What did the WIRE study say? 77% patients had moderate to severe calcified lesions, and the primary patency rate was 78%. Calcification did not influence the outcome in any of these two trials. So the Gore Viabahn stent is one of the most flexible stent in the market. It covers the lesion and prevents instant stenosis. No evidence that performance decreases in calcified lesions or across the elbow. Strong body of clinical evidence in long challenging SFAs, and now available in the longest SFA strength length of about 25 centimeters. There's another study, a Reline study, which is basically studying the role of Viabahn stent in instant restenosis. So this is a study which is still ongoing. There have been some data which has been put up in the Leipzig meeting early this year. And basically, this is a study which is randomized to PTA, angioplasty versus Viabahn in instant stenosis. And the inclusion criteria would be Rutherford class 2 to 5, ABI less than 0.8, and the target lesion length was 4 to 27 centimeters, depending upon the instant stenosis and the adjacent stenosis. So this is a study which should be coming out within the next year or two, and we'll be all looking forward for this indication. Now, I'm going to show you two of my personal cases of the Viabahn. This is a typical application of a 250 centimeter Viabahn stent graft. Gentleman with completely occluded superficial femoral arteries, very heavily symptomatic with the ABIs in the range of 0.3 to 0.4. So we will show the angioplasty on the right side. So basically, you cross in. There is no way you can do this case without re-entry. So we went subintimal, re-entered, and we Viabahn the whole thing with the 6 by 20, 250 millimeter Viabahn. And you always want to tackle the outflow. You want to go back kissing balloons, and you have a nice 3-vessel runoff. This was another challenging case, which patient had an aortobifem bypass graft, so the option of coming around was not possible. So the first time we came from the brachial artery, opened it up, but really did not stay with the balloon because you don't have a stent with such a long shaft. So we went popliteal, right popliteal artery, you entered, and then you end up with a proper Viabahn case. Just two more slides. Myths and musts of Viabahn. The poor patency rates with 5 millimeter stent graft is a myth. You need to have a 3-vessel runoff of patency of the stent graft, still a myth. Even a single vessel runoff is good enough. Calcium and length of lesion and covering the collaterals. If you have a lesion around the collateral, you can easily put the Viabahn across that. You must avoid oversizing. You must treat all the lesions, but you must never cover the profunda. Post-procedure DAPT, aspirin for life, Plavix 3 to 12 months. Confirm the inflow and the outflow. At least you need to have single vessel runoff. And the proximal edge flush with the superficial femoral artery is very helpful, and provide at least 1 centimeter overlap between the stents. Post-dilate the stent grafts. Do not dilate outside the stent grafts to cause injury to the vessel. And always use a Doppler for close follow-up. And also, if you have a disease progression, you must treat it promptly and quickly. Thank you very much, and sorry if I took some extra time. Yeah. Now I'll hand it over to the Zen master to take over from here.
Thank you very much. Thank you. Very nice talk. Dr. Sehgal covered practically all the statistic data available today. Now, I'm going to just talk a few minutes about the techniques for cover stent implantation. One thing I want to bring to your attention, that a cover stent is not really a stent, just a stent. It is a graft which is deployed percutaneously, so it deserves to be treated differently. The patency of a cover stent, just like any other grafts, depends on adequate inflow and outflow. But more important thing, one thing that most of people don't realize is competitive flow. Now, there are 5, Dr. Sehgal mentioned a few important points about implantation of the stent graft, but there are 5 points that you have to realize. Okay. Thank you. First of all, you have to put the stent graft from normal to normal areas. This is very important that you actually cover all the diseased area. This is an example of what I'm talking about. If you look at the, I don't have a pointer here to show to you, but if you look at the maybe upper 5 to 7 centimeters of the superficial femoral artery is, do you have a pointer? Oh, yeah, but you up there, not on my screen to show it. Yeah, thank you. But anyhow, this is the area that looks normal. So if you want, although there is only a short segment disease here, but these are all diseased area. If you want to use the stent graft, you have to cover all this area to normal popliteal artery. So we use a laser to reanalyze this. As you see, there was some calcification there, and put a vibe on from where we thought was normal down to where I think popliteal looks okay. If you look at the below the knee, all distal arteries are occluded. This is what Dr. Sehgal was talking about. It's not that it is not important to have a patent artery. It is if you have a good segment of the popliteal artery with branches of popliteal arteries, then it's immaterial that you have one vessel patent or 2 or 3. Don't leave any treated area uncovered. If you do a PTA or a atherectomy of a segment and you're putting a vibe on it, you have to cover that area. You can't put a vibe on in a segment of the SFA, then do angioplasty distally. Don't save the collateral arteries in diseased area. There is a big controversy and discussion between even authors about what to do with the collateral arteries. This is a 57-year-old gentleman with claudication of the left leg. If you look at it, there is a very large collateral arteries in practically diseased runoff. So pick up where you think you want to end up with your Viabon and ending zone in a healthy area. Just like, okay, we decided to, this is where we want to put the Viabon. That's where we want to end up, despite having mild stenosis below that. If you don't touch that stenosis distally, it's not that important because you all know a stenosis can stay unchanged for many years to come. So the total recanalization was done, and you see we used Outback device to get in. When you use Outback, try to recanalize to the top of the runoff. Don't go on the side of the runoff and sacrifice some segment of the arteries. We always use a distal protection. I personally believe in debulking, so I practically debulk every single SFA that I want to put a Viabon in. And then we dilate the artery, and you see this dilatation is done to the point that we decided ahead of time, and the Viabon is going to end up the same spot, same area that we dilated. And approximately, we want to go all the way to the ostium, cover the ostium of the superficial femoral artery. And that's a result. And this was done 4 years ago, and this Viabon is still open, despite that we left behind one mild stenosis of the popliteal artery. If we want to treat this, then we had to extend our Viabon down to here. There is a big talk about that length of the lesion has no effect on patency of the Viabon, but that's up to the certain length. A 25 cm long Viabon with normal arteries below it stay open a lot longer than a 30 or 35 cm. Debulk the arteries, as I told you, as it is needed, and don't oversize. This is the most important thing. Don't oversize the stent graft. It is better to undersize rather than oversize. If you are not sure to use a 6 millimeter or 5 millimeter, go for 5 millimeter. Now, what about collateral arteries? We talk about that, and there is I looked at 18 key articles about these collateral arteries. First of all, we're all born with certain number of when someone gets occlusion and you see these huge collateral arteries, it's not that they made those collateral arteries. Those collateral arteries were there. It got enlarged when the occlusion happened. The collateral artery can get 20 times larger than its original size, the size that we were born with. And they can carry 30% of the required circulation in coronaries and 20% in peripheral arteries. That's why sometimes saving a collateral artery is more important than go and recanalize the occluded artery, like the case that Jack did this morning. The collateral artery from perineal to dorsal pedis, it was so adequate, didn't make sense to go and recanalize the anterior tibial artery. There is another side to the collateral arteries. Collateral arteries don't get diseased, but once you recanalize an artery, it's going to get re-occluded again, no matter what you do to it. Now, angiogenesis is not arteriogenesis. Angiogenesis is a sprouting of collateral arteries in a capillary network. They are the small tubes of capillaries that they don't have smooth muscle cells, and also they're not surrounded by mirror cells. So what happened? They are very susceptible to breakdown. This happened in arteriogenesis. You get arterial occlusion, you have a steep gradient. That steep gradient causes shear force, and that stimulates excretion of the growth factor. Now, with competitive flow that I was talking about, competitive flow from collateral arteries to perfuse the tissue distal to a graft or an artery compromised by a critical stenosis. Now, this flow competes with the flow coming through a native artery or a graft that is still patent. Look at these images. This angio was done in an earlier stage, and you see collateral artery reconstituting a distal vessel. So if you stop right there, you think you have a total occlusion. Few seconds later, you see the flow is coming and finally comes through. Now, these two, this and the flow here, they're competing. Now, the minute that this flow gets a little bit more than the one up here, this artery is going thrombosed. So that's why it is very important not to let a competitive flow develop below where you put your vibe on. And if it is there, then you have to cover it. You get rid of it. This is what happened. You get the stenosis down here. This competitive flow would come when it gets greater. When the flow velocity of this becomes greater than in the viabond because of this stenosis, then it's going to get thrombosed. Now, if this wasn't here, this will last, and despite having the stenosis there. I look at the 18 articles, 10 of them didn't even address the competitive flow or distal artery, the collateral arteries. 4 of them advised totally against covering the collateral arteries because they were afraid of ischemia. A patient get acute ischemia due to thrombosis of the graft. And not knowing that that collateral artery that they saved is going to cause thrombosis of the graft. There were only 4 authors who said it's okay to cover them if it is in a diseased area. We look at 2 groups of patients, 30 with covering the collaterals and 30 of them not covering collateral. I'm going to go through this quick to finish and just show you the result. The one that we did not cover the collaterals at 12 months, they had a 66% patency. The one that we covered was 86% patency. At 2 years, the difference was 57% for the one that we saved the collateral arteries, 80% for the one that intentionally covered that. In conclusion, covering collateral arteries immediately distal to cover a stent prevents graft thrombosis, therefore improving your patency. Thank you very much. And our session is next session is going to start just in a couple of minutes. Until we get everyone over here, if you have any question for me or for Dr. Siegel, we'll be more happy to answer. Thank you.
to the Chicago Endovascular Conference. I'm Dr. Golzar. I have with me today Dr. Zarodi, who's our interventional fellow here. Today we're going to be demonstrating the use of the Axera device for access of the left common femoral artery. But we're going to be doing it in a really cool way with these point of view glasses, so you'll be able to see exactly what I'm doing from my point of view. So I use the Axera device because there's several advantages to it. I stopped using the standard access and closure devices several years ago when I had some complications with acute closure of the femoral artery. So we access the artery, and as you can see here, you have a latch at the end of the device itself, of the wire. Make a little net. Pull the needle out. And we're going to attach the end of the wire to the Axera device. I use this technique where I loop or where I scoop the device into the artery. You're going to see bleed back there. Deploy the fuel actuator. Pull back until you see decrease in flow. And then deploy the secondary needle. After deployment of the secondary needle, you're going to insert the ONA wire that comes with the device. And that secondary needle is what creates the super shallow angle arteriotomy. And the ONA device is now through that super shallow arteriotomy. Now we hold this and we pull this back, and that reverses everything. And then we very easily pull this back, and then you see the ONA wire. And we grab that and pull the rest of it out. Now you have the ONA wire through the secondary arteriotomy. Very easily place this sheath with the dilator adapter into the artery. Now that we're done with this, once we're done with the intervention, we're going to pull the sheath, about 5 minutes of hold, and we'll be done. 1 hour of bed rest for diagnostic, 2 hours of bed rest for intervention, with nothing left behind. That's how we use our stasis device. Thank you for joining us. We're going to go ahead and start the general session now. We're actually a little bit behind, so I'm going to introduce Dr. Sonia Noor. And she was supposed to be speaking on the last session, and she very graciously allowed us to go to lunch. And now she's going to go ahead and talk to us a little bit about calcified below-the-knee vessels and her use of orbital and rotablator atherectomy.
Good afternoon. So my name is Sonia Noor. I'm a vascular surgeon by training, and I have to thank the organizing committee for the invitation. I haven't been to this meeting, and boy, this is going to be a tough act to follow because I'm learning so much in the arterial and venous session, so really thank you for the invitation. So my job today is to talk about below-knee disease, which mostly means rest pain, critical limb ischemia with wound ulcer or rest pain. And most of these patients will have had wounds that you've tried to revascularize, that you're trying to heal. This is a typical patient who's had a transmetatarsal amputation whose now wound is still not healing. And sure enough, when you do the angiogram, your revascularization has probably failed, or if this is the first time around, it's not unusual for it to look like this. Being a surgeon, we've operated on these kind of arteries, and the calcium below the knee can be extremely challenging. You've heard it being described as popcorn lesions, severe calcification right at the tibioperoneal trunk, sometimes at the distal popliteal artery, and sometimes it's a wonder that the endovascular therapy even works on lesions like this. So BTK disease has always been very, very challenging, both for open and endovascular therapy. I wanted to focus a little bit on atherectomy because the talk I'm trying to give today is about rotational atherectomy or orbital atherectomy. And so the philosophy of atherectomy is the first thing you do is really modify the vessel compliance. So you're trying to do something to the artery without really plaque shift or damaging the artery, but change the vessel compliance so you can allow the blood flow. You debulk the vessel to some extent, and as you heard in the live case, you really don't have to take a lot of the tissue out, just enough out to, again, change the vessel compliance to allow pulsatile blood flow or inline flow. And I'll show you, you can do this with the rotoblator atherectomy, is sometimes you can actually gain access to a completely occluded segment without having to use a crossing device initially. Atherectomy doesn't have areas where it cannot be used. For example, we wouldn't want to put a stent in a common femoral artery. People are careful about putting stents behind the knee. Atherectomy is something that can be used in multiple areas, which is certainly an advantage. It preserves your future options because you're not leaving any foreign body behind. Those of us who have done this long enough know how many hours you can spend recannulating an occluded or stenotic stent. And especially in in-stent restenosis or occlusion, atherectomy can be very, very helpful and a good tool to use. So in talking about the philosophy of atherectomy, the first thing that you do is you change vessel compliance. So the picture that you see on the left is an angioplasty vessel in a porcine model. So what we're doing is we're cracking the plaque, we're injuring the vessel and allowing luminal gain. The problem is you start this whole inflammatory reaction, intimal hyperplastic reaction, and there goes the durability of your procedure. In doing atherectomy, the model on the right, you're looking at rotoblator doing this, where it's much more smooth channel. And whether it's laser or rotoblator or CSI, the concept is the same. You're just bringing the plaque down enough to change the vessel compliance enough to allow blood flow. The other thing about atherectomy is you debulk. Again, you have to be careful about how much you debulk, but the concept is you're removing plaque rather than just causing plaque shift. The technique has to be done with less vessel injury. If you're doing it to the point where now the patient's having pain, you're probably going too deep or you're working too hard and you're removing too much tissue. And the big thing that everybody has against atherectomy is embolization. And if you are over-aggressive, you will have embolization issues that can be clinically significant. This is a thing that I wanted to talk to you about, is sometimes your lesion can be so stenotic that you cannot even get a balloon across, or even if you do get a balloon across, it's not enough to give you luminal gain. It's not enough to give you a stent. Rotoblator has been a great asset for us in this, in which you can really wake your way in. So unlike a crossing device where you just put a crossing device through and gain a little bit of luminal gain, you can actually get your entire intervention done and cross the occlusion with rotoblator atherectomy. So the types of atherectomy devices can be broadly categorized as directional or non-directional or rotational. These are a few examples of one that are out, of which Silverhawk was probably the first, then Diamondback, Jetstream, and now rotoblator in the periphery. Now for years, rotoblator has been used in the coronary circulation, and I'm sure there are a lot of people in the audience who have used it in the coronary circulation, but it's only been approved, FDA approved for peripheral use in the last year, and we've been lucky enough to be one of the centers to start using this in the periphery and gain experience with this device. So to give you a little bit about the rotational atherectomy, which this is Diamondback 360, which is really orbital atherectomy. It's essentially a diamond burr that's it's present on a coil of 3 helically wound springs. And what that allows you to do is once you start spinning it, it takes an orbital route rather than just a circular route. And the importance of that is that it engages the plaque in a certain way. It spins in an orbit, so it gives you a little bit of direction, and then the orbit is large enough because of so much of heat generated because of the high spinning, it allows the blood to flow around it and cool, and it washes out the debris. So the orbital atherectomy spins at about 80,000 to 200,000 RPM. The grit size and high speed of the rotation allows very small embolic particles to then pass through the circulation, which are then picked up. So these are not usually clinically significant embolic particles because they're microparticles, they're measured in microns. So Diamondback allows you to have a faster spinning burr if you want to ablate and have deeper cuts, or a slower spin if you want a more superficial ablation, and that's dependent on the operator how they want to use it. Rotoblator atherectomy is a little bit different because it's a stable rotation, it's more concentric. You spin this at about 140 to 160,000 RPMs, depending on whether you do it above the knee or below the knee. And it provides a more predictable lumen size. It's very good at calcium, like a Diamondback is. And again, predictable microparticle release, if not used aggressively. Because of the front cutting burr, it can engage the lesion, and you can actually use the lesion to cross occlusions or stenosis, and you can control the ablation itself. It gives you a lot of feedback, and with our experience growing in rotoblator in the periphery, it gives you direct and efficient tactile response, just like when you heard when they were doing Jetstream cases today, the pitch of the equipment will tell you how it's engaging the calcium. It's very similar to that. You can get feedback, tactile response, and it really helps you treat those really tight occluded lesions. So to do sort of a head-to-head comparison, because the two of them are very similar, if you looked at rotoblator versus Diamondback, it's more of a stable rotation for the rotoblator. Rotoblator has front cutting. There's differential cutting on both, which means they will cut only the part of the disease that's hard. So they both work very, very well in calcium. I'm hoping this is going to play. Okay, so you see the rotoblator system is on top, the orbital rotation is below, and you can see how much of a lumen it makes because of the circular motion. Now, there are advantages and disadvantages to this. It obviously gives you a little bit more luminal gain because of the orbital path of the rotation, but you can also imagine in smaller vessels, it probably has a more higher outward force setting you up for vessel injury. When you look at the cutting surface or the front cutting surface of the rotoblator, this is a feature that I particularly like. If you look at it, it allows you to engage the lesion and almost acts like a crossing device and an atherectomy device. CSI is unable to do that because of the leading edge of the catheter before the crown can come in. So certainly an advantage, I think, on the rotoblator system compared to CSI. When you look at the microparticles, because these are 20 micrometer diamond grit on the rotoblator system and 30 to 70 micrometer grit on the CSI, the particles are extremely small. So if you look at it and compare it to a red blood cell, the particles are in the 2 to 5 micron area. If you use this aggressively, you will chip off larger pieces that can be picked up by an embolic protection device. But these particles will not be picked up by an embolic protection device because they'll usually catch 100 micron or more. Also, rotoblator is not a device that can be used with an embolic protection device because it has to go on a specific wire. And then if you look at the French size, I thought this was particularly interesting because as we're looking at more and more pedal access, it's possible we may want to do our intervention through a 4 or 5 French retrograde as well. And certainly both Diamondback and rotoblator are catheters that could be used. Now, obviously, wire length and device length would be issues, but these are things I think in the future that can be looked at and can be done. In terms of studies about what's out there, CSI obviously has been around for a few more years. They've had multiple studies. I'm quoting the OASIS study here, which basically looked at critical limb ischemia in 32% of patients. Most patients have heavy calcification. 86% were below the knee. The average lesion length was 30 millimeters. And they had about a 60% rate of standalone atherectomy and about a 40% of adjuvant angioplasty. Their acute success rate was pretty high, and their adverse event rate was fairly low at 2.5% death, 2.4% minor amputation, and 5.6% TLR at 6 months, which I think is pretty good. The problem with rotoblator is there's no contemporary studies. The last time this was really used in a large series was in '95, and we're hoping to be one of the centers to publish data with 25 or 50 patients at 6 months and 1 year to see how rotoblator performs in below-knee calcific disease. But based on the 1995 studies, similar to the OASIS, 24% had rest pain or minor tissue loss, 9% CTO, very, very calcified disease. Rotoblator performed very well at about 55% standalone, 44% adjuvant angioplasty only. Acute success rate was reasonably high at 81%. Remind you, this is in 1995. And their primary patency at 14 months was 14 months, pardon me. So in summary, I think atherectomy and below-knee disease is something that should be seriously taken. I think anybody who does endovascular therapy, this should be a part of your toolbox. There's a lot of advantages to atherectomy. Clearly, in my opinion, it is better than just angioplasty. It may be better than stenting. It may be as durable or more durable than stenting, but more importantly, it leaves nothing behind. So it gives you the option of going back and intervening, which if you've put a stent in and it's occluded, that's a lot of work to put in to try to open those up. Diamondback and rotoblator are obviously safe and efficacious and can be used in the periphery. I think it's a great place to use in a below-knee calcific disease area. Maybe it's a platform for a drug-coated balloon in the future, and that would be interesting to see how that plays out once a drug-coated balloon is available. And the other thing is, how are we going to compare below-knee atherectomy to drug-coated balloon below-knee? And I think those are studies to be seen in the future. So thank you again for the invitation.
Thank you very much, Dr. Noor. So if I could go ahead and invite our panel to come up to the table, Dr. Polina, Dr. Lopez, Dr. Goodwin, Dr. Walker, Dr. Dipple is here, and we're going to go ahead and, I think our live case site is almost ready, so I think we can squeeze in maybe one more talk, and then we'll go to our live case, I believe. And Dr. Polina is going to be speaking again about plantar loop interventions. When is it indicated, and how do I do it?
Okay, thank you very much again for inviting me to be here. Now, my topic is the pedal plantar loop intervention, when it is indicated, and how do I do it. So this is my disclosure again. I want to focalize my presentation in when I decide to treat the plantar arch and how. So I tried to treat the plantar arch when I have indications. It should be clinical indications, and it is related to the vascular lesions involving the arch, like in the case in which we can see only collaterals, but the patient present the forefoot ulcers. Otherwise, we do not have the indications without ulcers to treat the distal pedal vessels. But we can only find the technical indications. Patients that present ulcers need a complete revascularization, like in the picture, with this clinical situation, occlusion of the anterior, posterior, and plantar artery, and pedal vessel, sorry. And we failed to do everything through the antegrade access. In this case, I was able to obtain a complete recanalization, and as we can see, after 3 months, the patient's healed. So let me show a case, and we will be able to discuss. It's a patient with 84 years old, man, diabetes, dyslipidemia, critical limb ischemia, previous amputation, performing a transmetatarsal amputation with a very big ulcer. This was the situation, the vascular situation. He presented stenosis, tough stenosis in the passage between FEMPOP and occlusion of the anterior, occlusion of peroneal, occlusion of posterior. No vessels in the foot. So I approach posterior tibial artery with an 018 guide wire, as always, trying to stay intraluminal. And when it failed, I shift to a subintimal approach, performing the loop and going down, supported by a 4 French catheter. When I arrive in the foot, I decide to try to shift, and with the 014 guide wire, I was able to enter in the plantar artery, supported by a balloon. It's a 2 mm, 4 cm balloon, and with the 014 guide wire, I was able to enter in the arch, and after many attempts, I was able to perform a retrograde recanalization at the beginning intraluminally, and then I shift again to a subintimal in the pedal artery. And this was very useful for me because, as you can see now with the loop, I saw an strange movement of the guide wire that gave me the possibility to understand that there were anatomical variation with the dorsal circulation providing from peroneal artery. In fact, I approached peroneal artery again intraluminally and then subintimally, and I was able to enter in the pedal artery with the loop. Then I use a support balloon as a support. I dilate dorsal circulation and plantar circulation. I also, for sure, dilate the FEMPOP passage. And I obtained this kind of result with good no-flow limiting dissection in the SFA, impedency of the posterior and peroneal artery, and as we can see in the foot, with complete recanalization and direct blood flow for plantar and dorsal circulation. And this was the clinical result. The patient healed. So when I consider the loop interventions, when related to clinical indications, I need to recanalize the foot arteries. For sure, I fail in the antegrade recanalization of the target vessel. But I can also consider this technique in a subintimal recanalization without re-entering the landing zone to avoid to damage the landing zone, or in cases in which I have a suboptimal landing zone for re-enter. I prefer to perform pedal plantar loop technique to improve this re-enter, or in cases in which I am not able to understand where the origin of the tibial vessel is. Let me show another case. It's an 83-year-old female with diabetes, hypertension, obesity, CLI with a 16 millimeters AZ, gangrene in the 4th, and previous amputation of the 5th toe. It was the endovascular procedure again. Antegrade access in the proximal SFA with the stenosis in the SFA. And again, stenosis, subocclusion in the popliteal, distal popliteal, and occlusion of the anterior and posterior tibial artery with a good pedal vessel in the foot. My target in this case was posterior and plantar artery to give direct flow for the 5th and the 4th. So again, I approach with the 018 guide wire posterior in a subintimal, but I obtain this kind of situation, rupture of the posterior. So I change. I engage again anterior, tibial artery, go down with a support catheter, and again subintimal approach, hoping to re-enter in the pedal vessel. And after many attempts, changing the guide wire, I was able to re-enter with the loop of the guide wire. I check. And then with the 014 guide wire, I perform again the pedal plantar loop technique, and coming back to solve the problem. I use now a support catheter, a small balloon as a support catheter. I pre-dilate the re-enter point and was able to engage with the antegrade guide wire in the posterior tibial artery and go down re-entering in the plantar artery. So after that, I pre-dilate all the plantar artery and perform a definitive angioplasty of the posterior and anterior and plantar and dorsal vessels with a long balloon, as we can see, a long balloon in the anterior, and then in plantar and posterior, and this was the result. Again, complete recanalization with 3 tibial vessels and direct blood flow for the dorsal and plantar circulation, and complete recanalization in the foot, with very good blushing. In fact, when I finished the procedure, there were an acute bleeding of this foot. And this is the result. The patient performed a surgical reconstruction with a skin graft. And now this is the situation. The patient is going very, very well. It's not completely healed now, but it's going well. So how do I do it? Intraluminally, coronaric light technique in calcified vessels. When it fails, we shift to subintimal, but when we have calcium, we try to stay intraluminally, and for this, we use a 014 guide wires. Subintimal recanalization in not or in poor calcified vessels, and I prefer to use a 018 or in some cases a 035 guide wires. After re-enter, double guide wires in the foot to be sure that we are in the same lumen through the plantar to the dorsal and vice versa. And we use 014 guide wires again in the foot to avoid spasm. And this technique has 2 variations, so we can do from the plantar to the pedal or from the pedal to the plantar. So in conclusion, it should be done clinically driven. Antegrade first attempt usually, because in a lot of cases we succeed through the antegrade access. We need to use antegrade retrograde recanalization for complete revascularizations in some cases. But the most important point is the balance between risk and benefits. The benefits are the clinical benefits for the patients. The risk are to lose something that we have at the beginning. So we are able to take risk when we need clinical indications. Otherwise, we can stop and wait. Thank you so much for your attention.
Mariano, before you sit down, I have a question for you. So could you give us some tips and tricks on your technique for re-entry? So it looks like, you use the loop down in the foot and you kind of, I know some of it is skill, some of it is luck, but, getting back into that artery distally, do you have any other techniques?
Well, we have a lot of tips and tricks for re-enter because we work a lot in a subintimal space. But I think that everyone have his tips and tricks. However, pushing the loop is not the best solution. So you perform the loop in the guide wire and pushing down I did it, but when I arrived close to the orienter, I stop, check if I am in the subintimal space or not, check how long I am to the orienter, and in a lot of cases I change guide wire and try to re-enter with the tip of the guide wire. You need, again, to balance. If you have what we can call a good re-enter, you can push the loop, and in 99% of cases you re-enter. If the re-enter or the leading thumb is not good, it's better to stop. And if you don't succeed again with the new guide wire, with the tip of the guide wire, I prefer to change again for a retrograde axis. No risk.
And what type of wire do you prefer using? Hydrophilic, non-hydrophilic? What type
Well,
wire?
I usually use for subintimal space V18 from Boston, or now I have the new for me, these are not new, half stiff Terumo 035 J tip 1.5 that are very, very nice for subintimal space, but are too aggressive for re-enter. When I shift for 014, I prefer to use Command from Abbott. It's very nice, very stiff, and provide good results. And in some cases, some CTO guide wire like Wind from Abbott, or another CTO guide wire that I can't remember now, Asai guide wire.
Asahi, yeah.
Asai. But when you work with a CTO guide wire, you need, sometimes it's the best option, the more sure option, but you need to change a lot of time the projection to go in the perfect way, in the correct way. But it's possible, for sure.
Thank you very much. Great cases. I think we have time to keep going for a little bit. Our live case site is not ready as of yet. So we're going to go ahead and go to Dr. Craig Walker's talk, a friend of mine and a mentor, and he has an excellent meeting every year, the New Cardiovascular Horizons in New Orleans. He's going to be talking about the world's first tibial-peritoneal registry.
Jaafer, thank you so very much for inviting me to this meeting. I enjoy it, so do my family. They come up with me and we have a great time. This is me, and I have no disclosures related to this topic. Why even do this study? You know, I started doing pedal sticks 15 years ago, and when I presented this at one of the surgical meetings, I was nearly booed off the podium because people said, this is crazy, you can't stick a pedal vessel. But in truth, you can, and in truth, often it is the best approach. So we know that tibial-pedal access provides a viable route for crossing lower limb lesions that can prevent amputations in patients who've really run out of options. Even a great operator like Mario will tell you sometimes you cannot cross at all in an antegrade approach, and yet you suddenly stick a pedal vessel and you can come backwards and cross very easily. Often, total occlusions that can't be crossed from above can easily be crossed intraluminally from below, and that opens up options for atherectomy. Bypass is effective, but many CLI patients are simply not candidates because they lack adequate inflow, suitable autologous vein, or adequate outflow. Or often they have such profound comorbidities, they're just not surgical candidates. The tibial-pedal approach offers advantages over contralateral and antegrade femoral approaches, such as a decreased bleeding risk, ability to work from above and below concomitantly, and a higher incidence of true luminal crossing. So why a study? Well, there's a critical need for techniques to improve limb salvage in critical limb ischemias. We have a worldwide epidemic of this problem. The populations are aging and diabetes is exploding. But there are limited data in the literature on the use of tibial-pedal access for retrograde crossing of occlusions. It's mostly anecdotal. The purpose of this prospective multi-center study was to A, gather information on the range of techniques used, and second, measure technical success rate of gaining access in the first place, and then once access was gained, how often could we cross the lesions and treat the lesions? All techniques used were at the investigator's discretion and performed according to the institutional standard of care. So in general, what we were looking for was to determine technical access success and technical crossing success, as well as safety. The sponsor was Cook. The planned enrollment was 200. We only had 199 because one patient was double counted, unfortunately. This took place at multiple US and European sites, and the patient population just simply had to have an infrainguinal arterial occlusion. In most of these cases, previous attempts to cross the occlusion from an antegrade approach was required. However, a couple institutions, because their institutions allowed primary retrograde access, simply treated even some claudicants with this. All techniques to be used for access, lesion crossing, lesion treatment, and vessel closure were at the investigator's discretion, and the data was collected. Here we see those who were involved in the trial. Now, as it turns out, 2/3 of these patients were claudicants, had critical limb ischemia, and roughly 1/3 were claudicants. And the breakdown, pretty normal between males and females and ethnicity as well. Now, if we look at these, they were pretty representative of patients with peripheral vascular disease. Of note here is that 51.3% of these patients already had pre-existing tissue loss, and the overwhelming majority of those patients had had prior attempts at antegrade crossing, the overwhelming majority. But you can see as you go through this, 2/3 were diabetic, many had severe renal insufficiency, some actually on dialysis, and of course, many of these were smokers. Now, 67.3% of these patients had had prior failed antegrade access, and an even higher percentage of those that had true critical limb ischemia fell in this category. Angiography was used as the means by which to gain tibiopedal access in 63.3% of the cases, and in the others, ultrasound was used. Each of these has its advantages and disadvantages. Ultrasound requires no extra contrast. It can be done typically pretty safely, but as the vessel moves, it may be difficult. The access vessel in this study, the popliteal should not have been occluded. It was certainly far down, but you can see the vessels that were accessed, and there were even cases of the lateral plantar being accessed in this study, a true digital access. Access was unsuccessful in 6.5% of patients, and we'll get into some of the reasons why that is. Now, if we look at the lesions that were treated in this study, certainly the initial target was never going to be the iliac or the SFA, but these were often treated as well as all of the popliteal and infrapopliteal segments. If one summates this, you can see the numbers come out to far more than 100%, because in the patient of the iliac stenosis, this was a patient who had an iliac occlusion, an SFA occlusion, a popliteal occlusion, and infrapopliteals that were occluded, and all those vessels were crossed and treated in that setting. So what happened here? In terms of technical access success, you were a little more able to access the claudicants than the patients with CLI. 96.9% of claudicants access was successful. In the CLI group, 91.9%, slightly less. Technical crossing success was exactly the same, claudicants and CLI patients. More of the CLI patients tended to have really severe infrapopliteal and popliteal disease, less so disease up in the SFA. Now, 13 patients in toto could not be entered. The vessel we could simply not gain access. And if we looked at these patients, we wanted to understand why. 9 of these 13 patients had really pretty severe calcification. I must say in my own series, there was one case that I did have successful access, but I actually bent 7 needles getting in. It was a patient who had been on dialysis for many years. And so we were persistent and finally got in. But it can be a real problem in that these vessels may actually be rock hard. But something that I think people don't think about is simply size of the vessel. And even though females represented a very small percentage of the patients, more than 2/3 of the failure to gain access were in females. And I think this is as simple as the vessel is smaller. So if you've got a diseased, smaller vessel, you've got a smaller target to hit, and that's a bigger problem. Now, how were these patients treated? The vast majority were treated with bare balloons. Some were treated with drug balloon. Again, this is going to be more than 100%. Some were treated with bare metal stents, drug-eluting stents, thrombolysis, thrombectomy, directional atherectomy, rotational atherectomy, laser. Some were not treated. They couldn't cross across everything. Other consisted of specialty balloons. When the study was designed, there was not a category attributed to other and specialty balloons, and so those were included there. As we look at the adverse event rate, it was very low. Again, early on, surgeons predicted this would be catastrophic. It simply was not. You had local pain at the access site. One patient had infection at the access site. This was treated with a week of oral antibiotics, nothing more than that. Bruising at the access site, which one sees, bleeding at the access site in 1%. There was one patient that had vessel dissection. They'd gotten into a subintimal plane going up. There were no cases of compartment syndrome, no cases of urgent surgical revascularization, and no cases in this trial of acute vessel thrombosis. And all of these patients were studied by ultrasound prior to being discharged. Now, if we look at the ischemic events at 30 days, we see that 4.5% of people had gangrene, and these, of course, fell into the ischemic category, and 3% in ischemic ulcer. 1% went on to have bypass grafts. Many had debridement. Minor amputation, which was in most cases planned ahead of time. Major amputation occurred in 3.5% of these patients. And if we look at that group, 5 out of 9 of those were in unsuccessful cases where you simply could not cross and treat. If we look at Rutherford scores after, we can see they certainly shifted quite a bit. So in conclusion, there were high rates of success achieved for tibiopedal access, and I think it will get better in the future with better tools and better understanding on our part. And retrograde crossing was very high, despite some cases being unbelievably tough cases, occluded from the origin of the iliac through the infrapopliteal vessels. The tibiopedal approach is safe, and it can be performed via a variety of the access vessels, including digital branches. It is an important option for promoting limb salvage in patients where lesions may not have otherwise been crossed, and I couldn't agree more with what Mario said. We always, in our own series, try to cross first antegrade. But if we can't, we don't ever run away from this and not consider this as an option. And this approach is used both as a primary and a secondary access method for patients with a wide range of Rutherford scores. There are many people now suggesting this should be done because there's less risk of bleeding. I'm not sure I agree with that yet. I'm not sure that may not lead to some complications in certain patients, but we will see, and data will tell us that, and studies like this are that data. With that, I really appreciate your attention, and again, I want to thank you for the pleasure of invitation.
Okay, thanks a lot, Craig. I think we're ready for our live case. Yes?
Are we here?
Yeah, Tom, can you hear me?
Yeah. I can hear you. Can you hear me?
I can hear you. I can see your ocelot catheter on the screen. This is Eric and Jaafer, and we have the rest of the panel here too.
Hi guys, how you doing? So you guys can hear me?
Yeah, we can hear you.
Yeah. Okay, great. We've been working here a little bit. I'll show you what we've done so far, because I wasn't sure how far we were going to get with this. Again, I was wishing Craig was doing this case and me doing a talk up there. But this is a gentleman who is from the nursing home right now. He had a ulcer last year that was non-healing, and in September he ended up having a left popliteal bypass. And so you can see this is the shot of his left leg. Anyways, he ended up having a transmetatarsal amputation.
Tom, we actually just have a shot of the ocelot catheter. So if you could switch it over to...
Sorry? Now can you see it?
Yeah,
now
there we
can
go.
see it.
Perfect. Okay, so we went ahead and did this, and you can see this is where he, so he had a transmetatarsal lamp, and it was not healing. They did ultrasounds and found out that the bypass graft was occluded, and so they had recommended an amputation at that point. I think you can see probably where the origin of that popliteal bypass was right there, down below. I don't know if you can see that little nub down there.
Yeah.
Very well. And then this is where you can see there's some reconstitution down here. And then we've got some more pictures here. I'll show you where the total occlusion is at the popliteal level. So I think you can see that.
Yeah.
So this is where we started. What we did was, can you play this ocelot? What we did was we actually used an ocelot because we thought this would be, with all these branches and geniculate branches and collaterals, we were concerned about getting into things. So we, and it looked like a small vessel distally that we had to get into. So we actually used an ocelot, and you can see it on the screen here. Can you see this?
Right now we see the angiogram.
Can you show the ocelot, guys? Back it up, back it up. Can you show, are you showing the ocelot, guys, now? Do you guys see that ocelot?
No, we're
guys?
still seeing the popliteal angiogram.
They're just seeing the popliteal angiogram.
There we go. There we go.
Let me know. Okay, you got it? Okay.
We had it
So
for a
what we
second,
did
now we
was-
see you. We had it for a second, now we're seeing you.
Yeah.
There, there we go, there we go, there we go.
Okay. Okay, so what we did was we took this down here, and can you start over from the beginning? We're going to start over from the beginning to cross. So the concept, again, here's the start of the catheter. You can see at 11 o'clock is sort of those layered structures. It's a little bit grainy for you, but it was more clear for me. So we tried to, and you can see we're in a fibrotic area right here by OCT. As we crossed in here, we came down through here, and you'll see we ended up popping into, we tried to stay with our layered structures with the middle marker at it. And you can see now we passed and we've injected, and you can see actually a large vessel there. So that's where we ended up with that. And then I think you can see this is our ocelot coming down there. And then as we got through, popped our wire down there, and you can see this is the angiogram through the ocelot. So we're able to pop, we just popped a wire down here, wherever it went. And unfortunately, he moves a lot, so my digital angiograms aren't that great. I apologize for that, but.
They only saw the ocelot.
Okay. So can you go back to the angiograms for these guys now? We're on the angio now? Okay, so there's, can you see the angiograms now?
Yes.
Okay, so that's the start of it, and this is where we popped through, and you can see this is an image shot through the ocelot. And so we see our wire was in a small branch there, so we ended up pushing it down as far as it would go. And it looked like we got into a perineal branch. So we took a catheter down there and took a quick picture, and this is what we got. And we took a little lateral picture because I knew I wasn't in the anterior tibial. And you can see there's that collateral going to the anterior tibial. So this is where we're at right now. We're going to try to open up the popliteal, and then maybe I'll take an angiogram there of the popliteal again, see if I can get a better picture of it, and make a determination on what we're going to do. And then we'll try to get the below the knee stuff. I'm going to take see if I can get, where's my catheter here?
So
I'm going to try to take a picture without digital subtraction, just to see if, well, he's not moving much now, so let's see if we can get a good picture here. Actually, just with our ocelot, we've probably got a good open vessel there now.
So that's an atherectomy catheter as well?
No. Tom, Craig Walker here. You know, I like the thought of using this optical coherence guided tomography crossing in this case. One, it takes out the issue of not being able to see through the prosthesis. which is often a problem. But I think more importantly, it made sure that you stayed intraluminal. And so now your options for atherectomy are so much greater here if you're trying to avoid stenting of this segment. And I think that makes this a very nice choice in this situation.
Yeah, and I think the other nice thing about it too is, Craig, is with all those geniculate branches that you have there typically, when you steer this in there, you know exactly, because you have, it's within, you got layered structures immediately all the way around the catheter, so you immediately know that you're in a geniculate branch, so you can pull back and reorientate to there. And this wasn't that hard to cross. So I think he's not moving around already, so he's probably having less pain right now. So any thoughts on what you want to do to treat this? I was thinking, actually, now that I'm seeing this, I'm almost tempted just to use a scoring balloon on this, just to see what kind of result I can get, but wouldn't be opposed to atherectomy at all. What's everyone think?
I agree with you, Tom. This is Jaafer. I think just a balloon angioplasty, nice long balloon angioplasty there would be nice. One thing I did want to bring up is you've probably had one of the highest number of cases of ocelot in the country. The learning curve is definitely there for this catheter. Could you give us some tips and tricks as you're continuing to work?
Well, you know what, the biggest thing I've learned is trust the OCT. When I first started doing this, I was always looking at OCT and or at the fluoroscopy, and I was thinking, okay, it's not directed in the right area, but the OCT was telling me I was. And so I learned to follow the OCT, and then I just learned to keep my foot off fluoro altogether. We have a pretty good series of cases, of 50 cases, where minimal fluoroscopy, less than a half a minute of fluoroscopy crossing total occlusions, just really using the OCT guidance. And so we've been successful doing that. And I think the biggest thing is just OCT helps you to figure out where you're not supposed to be. Media and adventitia are very evident on the OCT. So if you're starting to get in the media or you are getting into the adventitia, it's clear. And if you don't see those two things, you're probably in a good spot. And then you can just keep on pushing through. So I think that's the really key that I found out, knowing where you're not supposed to be. It helps in that degree. So anyways, I want to move on to see what we're going to do here. What's the panel's vote on either atherectomizing this or just doing a scoring balloon?
Tom, let me ask you one question before I give my vote. Did you determine how big this vessel is? Because I don't know your magnification scale. And you had OCT in there, and maybe you could have gotten a measurement from that. How big is the vessel? Because that would affect my thought process.
Well, on the ocelot OCT, I cannot, but I can throw an ultrasound down there if you want. Can I get a quick ultrasound?
I would like it if we have time. In a bigger vessel, I might consider a specialty balloon alone here. In a smaller vessel, in a bigger vessel, I would consider specialty balloon alone. If the vessel were on the smaller side, let's say 4.5 or so, I would always atherectomize and follow with a balloon, because my experience with smaller vessels here that were total occlusions, if I'm not leaving a stent, is that I get a very high rate of restenosis. And so that's what matters. I think a bigger vessel, you simply stretch bigger, you have a bigger initial lumen, and I think that would change my approach.
Yeah, I agree with that. The only other caveat I would put on is that the very cap typically is where you're going to get restenosis at. And so I would be in favor of ballooning this whole segment, but you have to do something different at the cap. You know, either a short atherectomy or a very short stent or something just to kind of prop that area open.
You know, in a few months, we're going to have drug-eluting balloons, and I think drug-elution technology would be perfect in an area like this. Obviously, it's not here yet, but in a few months.
Oh, we're gonna travel over to Germany and try to get some of those. But no, I would agree with you. I think a drug-coated balloon here would be very, very nice. Are we able to put the ultrasound up here, guys, for them to see? So, my gut tells me it's going to be about a 4 millimeter, maybe a 4.5 millimeter vessel. With that OCT, it's really hard to judge the size of it unless you do regular OCT, you know, the St. Jude OCT. But with the Firefly or Fire, whatever it is, I keep on remembering. Can't remember what the name of it is every time. But are we able to? Can you guys see the ultrasound up there?
Yes.
You can.
Yes.
You're in the catheter, so go, keep going, push, push, push. Okay, ring down here. Bring down. Bring down. Okay, perfect. Push in. Okay, keep on going. So I'm going to see where we're at. You can see pretty heavily weighted plaque. Keep going, keep going. Keep going, keep going, keep going. So that's the outflow, right? Right here is going to be the outflow. I don't know if you can see on the screen as well, too. But so that's probably 3 millimeter vessel right there in the very distal pop. And then where we're actually coming into the P2 segment here, you can see that it's not a huge vessel. It's probably about 4 millimeters again.
Actually, Tom, if you look at your scale's at 2 millimeters per marker there.
I'm sorry, 2 millimeters. You know what? You're right. I'm sorry. I didn't look at that. Thank you. So I was going to say, this is an awful small vessel. So we're about 4 down here and probably up closer towards the top. This is the origin of it. 2, 4, probably almost 5.5, 6.
Yeah. So the lumen's nowhere.
It's pretty eccentric. You can see we got a pretty clean crossing too. So let's take it out.
Yeah, lumen's nowhere near as big as it looks angiographically. I would tend to atherectomize here in balloon.
Tom, it's Lou Lopez. The other thing that I would suggest is looking at these images. The plaque burden in there is enormous, and it just seems intuitively obvious that you're likely to get a better long-term result if we debulk a little bit before we balloon.
Yeah, that IBIS was really helpful.
Actually, I had planned on doing that right off the bat, but so fortunately I have one of these devices sitting right here waiting for us. I'm glad you guys agreed. So anyways, we're going to go with LXC Turbo Hawk. And okay, so I want to pop that through there. But I think the other problem too is that, you know, right now my wire's in the perineal and it gives a collateral to the AT, but this guy has a non-healing transmit. So ideally we want to still get into the posterior tibial vessel if we can, which is going to be my next challenge after this. So I think this is the first thing to get good flow down here with this, and then we can maybe
Tom,
see a little bit better as we're going through here.
If you could switch off of the volcano and on the camera.
Yep, could you guys go on to the angiogram now? Okay, pass this through all the way through. So I'm just going to pass it through, just make sure it goes through, and as it does. And so we'll take one small cut here, nice and slow. Okay, keep going. So you guys can see this, right?
Is that an LX, Tom? LXC or LX?
Yeah, this is an LXC. We're just going to come through here. Because it's small down there, I'm going to take one. Now, I didn't pack much there, so as you remember, that ultrasound was very eccentric, so. But it looks like I did get some. So I'm going to try one more cut in the other direction. Keep pushing down. Push, push, push. Push in there. So we'll try taking one more cut here. Keep going, keep going. In this direction here. Nice and slow. And I'm going to be careful because I don't want to obviously perforate this here if we can help it. So that's I'm just taking pictures right after each cut. Normally I would probably, if it was the SFA, I would probably just go ahead and take multiple cuts. But certainly with this area here, I don't want to do that. So a little bit more. Okay, that's good. Surprisingly, I'm not getting a lot of tissue packing, so as heavy as that was. Okay. So what do you guys think now?
Well, it definitely looks a lot better.
So I'm going to take a picture down below to see what we got now. See if I can get a better idea of where we're at here down here. We really didn't see much beforehand. And like I say, he's a lot more comfortable, so I have a feeling we already did something for him. So there's a good anterior tibial down there. We'll take another picture down here, mid-level. And then so the anterior tibial is totally occluded there, and it's patent at the foot. Problem is I'm not sure where that PT comes off at all. Just want to get a series of pictures down here and see what we got. So he does have a PT down there, and he's got an AT down there. I'm almost wondering if I can get through into that PT through that communicating vessel there. So let's go back and see if we can find out where everything comes off here. So I'm not seeing a good posterior tibial. I'll try to get one more picture up here with an angle to see if we can get a better view of it and see if we see something there, but I'm not sure. I don't see much. I'll try to get it right here.
Tom, is this limb salvage or severe claudication?
Limb salvage.
He has a non-healing.
If you missed the first part, he had a wound with a pop bypass, and which failed, and he's now was recommended a below the knee amputation at this point in time, and because since September his transmet has not healed. So. Certainly, I don't see much down in the posterior tibial branch coming off. Do you guys see anything that looks like a PT?
No, but I see the stump of the anterior tibial. You may want to try and push through that.
Yep, that's what I think I'm going to do. And I think what I'm going to do is I'm going to see if we can. So let's take this out. I think what I'm going to do is I'm going to see if we can even, because it looks like there may have been a communicating vessel down there to it. I might be able to just do a loop wire.
Tom, his original surgery, he said it was to a popliteal to where bypass?
They called it a popliteal bypass per the report. Can I get a? He showed up in my office just a couple days ago. Can I get a O&A quick cross? We got one right here. Okay, we got another one here. Yeah. So what I'm gonna do is I'm just gonna change this wire out. We'll get the quick cross down there and see if we can get down. Why don't you give me a gold tip glide? So,
hey, Tom, we have about a minute left of satellite. We can come back and see the final results. What are your plans from here?
Well, what I'm going to do is I'm going to try to get through this. I'm going to bring another wire down, try to get through this anterior tibial, communicate to that pedal vessel. And actually what I'm hopefully going to do is it looked like I said, there may have been the communicating vessel into the posterior tibial, into the plantar vessels. Because that's what I'd obviously like to get, and if I can, that might supply enough then to salvage him for his transmet. Okay, so we're already past there. So we're going to come up here.
Yeah, what we can do is I think we're going to give a couple talks, and we can come back to you in a little bit and see what your final result is. How's that sound?
Great. I'll see you guys in a bit.
All right, thanks a lot.
I'll enjoy the talks while I'm listening too.
Next is going to be Dr. Eric Dipple. We're going to go through tibial interventions now and now kind of seeing how to cross it, multiple modalities of treatment from regular wires all the way to high-end technology. And now it's how do you treat these patients? Once you get through, now how do you treat it? And Dr. Dipple is going to launch this sort of three-prong approach out.
Thanks a lot, Jaafer, and thanks for the invitation to be here. It's a pleasure. So this is always a slide I like to start with when I'm talking about plain balloon angioplasty, because we've come a long ways in the last 40 years since Andreas Grunzig designed some balloon catheters on his table out of some tubing while drinking some wine. And now we're to the point where, as you've seen in previous lectures, that we can do these pedal arch reconstructions. So we have long balloons that have low profile that can really go pretty much anywhere we need them to go. I'm not really aware of any atherectomy devices that I think could safely navigate this. Possibly a 0.9 laser may be the only thing I could think of, but really I think balloon angioplasty is the staple of what we do. And I think the biggest part of my talk is not necessarily that angioplasty alone is going to always be sufficient, but I'm really going to try and concentrate on the art of angioplasty and how I think it's been lost over the last few years since advent of atherectomy and stents and so forth. And we really need to actually go back to some data that's 20 years plus old to kind of understand how we've gotten to this point today. So, what are the treatment goals? When you talk about tibial intervention, we're really not intervening on tibial arteries very frequently for claudication. It's usually for an indication of CLI. And so our treatment goals for CLI obviously are limb preservation to try and heal up the ulcers and avoid as much tissue loss as possible, relieve the ischemic pain, and improve their quality of life. And from an endovascular therapy approach, we're trying to establish inline flow all the way to the pedal arch, as I showed on the first slide with the angiogram. One of the things that I think is important that we kind of lose sight of is when we're talking about our treatment goals, the long-term vessel patency doesn't always correlate with limb salvage. And I think that's been very well established. In the first few weeks and months that it takes for the ulcers to heal up, you need much higher oxygen demand to bring nutrients and so forth to regenerate tissue. But then if vessels lose their patency, that doesn't necessarily mean the ulcers are going to automatically come back. And so I think with aggressive wound care team approach and aggressive surveillance, we can get these to heal up, even though the vessels themselves may not maintain a long patency with a plain balloon angioplasty approach. So with revascularization for CLI, again, late loss, the late loss of a revascularized artery may allow an ample time for tissues to heal. There may be enough perfusion in the weeks and months for the ulcers to resolve, but there may be a disconnect between long-term vessel patency and limb salvage. And I think that's very important that we keep that in mind, is what are our goals and what are we trying to accomplish when we're picking our devices. There's been data that's 10 plus years old now that plain balloon angioplasty works for critical limb ischemia. This is 284 patients by Gerald Doros. This is a 5-year follow-up. The limb salvage rate was 91% with a relatively low amputation rate. So we know that plain balloons work, but really I think we need to go back to the mechanism of how balloons work to try and understand how we can achieve some decent long-term results. The concept of angioplasty is not simply plaque compression. When we dilate arteries, we're not just smashing the plaque out of the way. What we're actually doing is controlled fracture of the plaque, stretching the vessel wall, and that's what achieves our luminal expansion. This has been well documented, again, from the 1980s and 1990s, and it's something I think we need to keep in mind when we're doing our procedures. This is a patient that I just worked on about a week or two ago. It's actually been a couple weeks ago now. A 77-year-old gentleman who has had a known history of popliteal artery occlusions for at least 10 years, who's been having more rest pain recently. His ABIs are 0.3 bilaterally. On the left panel, that's his popliteal stump up at the top, and just what I call a cobweb of arteries distally into his foot. There's maybe you can identify a perineal artery in there, but there's really just a cobweb of small, tiny collateral vessels. I went through this with standard angioplasty techniques that you've seen in the last few speakers. I did put a stent into the distal popliteal artery down to the bifurcation of the anterior tibial artery, but all the way down into the foot, I just used simple balloons, 2.5 in the anterior tibial and a 3.0 on the posterior tibial, 300 millimeter balloons, long inflations. The patient came back about a week later to fix his other side, and so I took a picture of this is the side that I fixed a week earlier. The vessels are widely patent. His ABI was 1 in the office, and his pain is essentially resolved. And so, this is now about a month or so after I've done this case, and so his vessel patency may not be that long, but I think that in the short term we've achieved the results of making him feel better. So the important thing, though, is that cell membranes have a viscoelastic property, and the simple thing to think about in this is silly putty. If you stretch silly putty slowly, it will stretch. If you pull silly putty very quickly, it will break. That's viscoelasticity. And we have to think about that when we're doing balloon angioplasty for the same reason. If you take cells, smooth muscle cell, endothelial cells, and you apply a strain to them, here, for example, 10 pounds per square inch, If you apply that over an 8 millisecond impulse, you're going to have cell injury. If you apply the same load over 1.75 seconds, you're going to have no cell injury, okay? It's how long of a period of time this is stretched. This is a porcine model. This is a 3 millimeter pig artery that was stretched with a 4 millimeter balloon. You can see on the panel on the left that when you inflate the balloon very slowly, the artery will stretch. When you inflate the balloon very quickly, you get a significant amount of vascular trauma and injury. And so if you keep that in mind, that long, slow balloon inflations are much more effective than rapid up and rapid down balloon inflations, I think we can achieve better angioplasty results. One of the problems, however, is the plaque. The plaque is very heterogeneous. There's a different composition throughout with calcium and atherosclerotic debris, and so you get unpredictable acute results. And so you get these wastes on the balloon that then pop very quickly, and that's where you get fracturing of the plaque. So how can we achieve a more predictable plaque fracture? Well, that's through some of the specialty balloons that have been developed lately. This is using finite elemental analysis on plaque composition. When you take a balloon and inflate it at 1 atmosphere, this is the kind of stress you get. However, when you put a stress concentrator inside the artery, now you can apply much more focal force into the artery and get a more controlled fracturing of the plaque and less barrel trauma to the wall of the artery. That's where the thought process behind these scoring balloons has come from, with the cutting balloon, the angiosculpt, or VascuTrack. The rationale is to use a stress concentrator to fracture the plaque at a lower inflation point before the balloon is fully inflated. So you get an enhanced lumen enlargement, more predictable angioplasty results, and the rate of the stretching is going to be less, and so you're not going to get that popping effect where the artery tears suddenly. Focal force angioplasty creates a controlled longitudinal stress pattern. You get higher stresses at very localized areas, which ultimately can give you larger luminal diameters, lower recoil, and less vascular injury. The chocolate balloon is also another type of concept of a specialty balloon, which is a newer generation balloon that has a nitinol cage over the balloon that allows the balloon to not overexpand. The nitinol cage is approximately 80% of the size of the nominal size of the balloon, again, to minimize dissection and provide less traumatic injury to the artery. Skip through that. Okay, so in conclusion, I think, in my opinion, that the pre-stent era of angioplasty has been lost. I think if we're going to try and rely on balloon angioplasty alone, we have to keep this concept in mind that arteries have a viscoelastic property, use long, slow balloon inflations. I typically do 5-minute inflations. I've actually done 20 to 30-minute balloon inflations at times, and the results are very good. If you have that kind of time, just blow up the balloon, go outside, do your paperwork, come back in, and you'll be surprised at what the arteries look like. New specialty balloons, I believe, kind of merge the past, the present, and the future of angioplasty. Low pressure, atraumatic inflations are important to reduce deep medial wall injury, and new generation balloons are specifically engineered to reduce dissections, lower stent use, and potentially could yield superior results. Thank you for your attention.
Next we have Dr. Lou Lopez, who's going to be telling us about the role of atherectomy for tibial interventions. One of the important things that actually Dr. Dipple had brought up, and we teach this to our fellows all the time, is we say low and slow. You know, as cardiologists, we're used to, you know, cranking it up and waiting 30 seconds and then coming down. Going up really slow, allowing that vessel to stretch and that plaque to really stretch, and then, you know, keeping it up for several minutes, I think is very important.
Yeah, patience is the hardest thing to teach and the hardest thing to practice. All right, so my name is Lou Lopez. I'm an interventional cardiologist in Fort Wayne, Indiana, and I'm going to talk to you about tibial atherectomy. A lot of what we do in treating tibial vessels is for critical limb ischemia, and I urge everyone to always consider the indication for what you're doing prior to embarking upon any intervention. CLI, the indications are obvious and clear. I think many of us feel very comfortable treating claudication below the knee. If you are skilled and confident in your ability, I think that's great. If you're a novice, I'd probably stick with CLI at the get-go until you have high skill level and you can do tibial work without any kind of complication. For below the knee work, absolutely would not treat asymptomatic patients. I read a lot of Doppler studies where I'll see a segmental occlusion of a tibial vessel in a patient that's asymptomatic, and I just tell them, you know, medical therapy is what's appropriate. It's hard to improve upon asymptomatic. All right, so why tibial intervention? Why atherectomy? Well, a lot of what we treat are diabetics with CLI, and 75% of these patients have disease that extends below the knee. 66% of those lesions are total occlusions, and 55% of those are greater than 10 centimeters in length. When we treat with plain old balloon angioplasty, we see high rates of early elastic recoil, maybe not if you do it for 30 minutes, but I freely confess that I don't have that kind of patience. We see higher rates of dissections, abrupt closures, and we see restenosis that occurs due to intimal hyperplasia that occurs earlier and more frequently because these vessels are small in size and the lesion lengths are very long. So I put this in here because I didn't want everybody to forget, when treating these patients, one of the fundamental cornerstones of treatment of all this disease is optimal medical therapy as well. So don't ever forget that. That's first and foremost. When doing atherectomy below the knee, we have many choices now. 10 years ago we didn't, but we have directional atherectomy in the form of the Silverhawk, laser atherectomy. We have orbital atherectomy with the Diamondback. There is a rotational atherectomy that aspirates at the same time, the Pathway device, and another rotational atherectomy device, the Phoenix by Athromed. So I'll start, I just want to give a brief review of some of the data surrounding these devices. There's somewhat of a paucity of high quality data regarding atherectomy, and I think that that's going to improve probably in the next 3 to 5 years. But I have to salute Covidian for having done a worthwhile study with their definitive LE, and they looked at about 600 claudicants, 200 patients with critical limb. There were about 90 patients in each group that were below the knee. So we'll start with the claudicants. They looked at 93 patients. Average lesion length was 5.5 centimeters, and they documented 90% patency at 1 year by duplex ultrasonography, and that was core lab adjudicated. So I have to say that's the sort of data that we need below the knee so we can start making decisions about what modality works, what doesn't, what can we expect out of these treatments, et cetera. Looking at the critical limb, there were 96 patients in that group, 6 centimeters average lesion length, 78% patency by duplex ultrasonography, again, core lab adjudicated, and 95% freedom from amputation at 1 year, which is an important thing to mention, but a much softer endpoint than vessel patency. So clearly you can see claudicants, less severe disease, better patency at 1 year, critical limb, expectedly lower levels of patency at a year. If we look at wound healing, at 3 months they saw 50% wound healing, 6 months 60% of the wounds were healed, and at 1 year 72%. With atherectomy, as opposed to plain old balloon angioplasty, diabetics seem to perform equally well to non-diabetics, and in terms of directional atherectomy, the limitations of the device, as previously mentioned by some of the other speakers, are perforation and distal embolization. Those are the things you got to watch out for. Looking at rotational atherectomy with the Diamondback 360, device is both 4 and 6 French compatible. As mentioned, you can go with a smaller device, sheathless through a tibial vessel if needed. The burr sizes create a larger lumen than what the actual burr is due to the centrifugal force of the treatment algorithm. The Diamondback 360 also allows blood flow through the treatment zone during lesion engagement. The handle that you move the burr back and forth on has a 15 centimeter throw on it, it's pretty broad and it's generous. And the particulate matter is very small, 90% smaller than most red blood cells, and smaller than 99% of all capillaries. Electric motor drive, it works by the diamond blades generating resistance against a hard plaque and grinding that off while allowing the elastic healthy tissue to rotate or to move out of the way. Their primary below-the-knee trial was the Calcium 360 trial, looking at orbital atherectomy plus adjunctive balloon angioplasty compared to balloon angioplasty alone. They looked at 50 patients, 64 lesions, 72% were diabetic, 95% had moderate to severe calcium, and these were Rutherford class 4, 5, and 6. Balloon inflation pressures were lower in the group treated with atherectomy, as many of us have already witnessed and practiced. So 5 centimeter or 6 atmospheres were required to dilate the lesion in the atherectomy group versus 9 in the balloon group. Acute success rate was higher in the atherectomy group, 93% versus 82%. Flow-limiting dissections were lower when pre-treated with atherectomy, 3% versus 11%. The atherectomy group had 0 perforations, balloon had 3%. Bailout stents were lower when pre-treated with atherectomy, 7% versus 14%. If we look at their final conclusions, 12-month freedom from target lesion revascularization in the group with atherectomy plus balloon was 93%, 80% for balloon alone. 12-month freedom from major adverse events, including death, amputation, and revasc, was 93% for atherectomy plus balloon versus 58% for balloon alone, with a highly statistically significant outcome. Laser atherectomy, advantages, it vaporizes the plaque, it doesn't cause barotrauma to the vessel. The laser wires come in a variety of different sizes. The smaller sizes are very easy to use from tibial access sheathless, very low risk of perforation. It's one of the lower cost atherectomy devices. The limitations are that it does not have as high a luminal gain as some of the other atherectomy devices, and it's not effective in calcium. But they did a trial. This is an older trial, but still a reasonable trial. The Lacey trial, 145 patients with CLI, Rutherford 4, 5, and 6. It was laser plus balloon or stent, and they demonstrated 92% limb salvage rates at 6 months. Looking at rotational atherectomy with aspiration is the Jetstream device. It comes in a variety of sizes, both for above and below the knee. The larger sizes have blades that you can extrude to increase the treatment radius or retract when you're going into a smaller vessel. The device aspirates as you treat, so it does capture a little bit of the particulate matter that's generated by the atherectomy device. But where I find it a little bit more useful is when doing CTOs that, whether you understand this or not, does harbor a lot of thrombus within the occluded segment. You actually will have areas that are significantly stenosed or occluded with hard plaque that are abutted by many areas that are just thrombosed, and then you'll have another area of hard plaque. And a device that aspirates some of that as you go through helps to reduce distal embolization. It's got true front edge cutting, very effective on calcified lesions. They've done only thus far a pilot trial, 172 patients, 210 lesions, 42% were diabetic. And 1-year patency by duplex ultrasonography was 62%. However, I will also point out that their average lesion length was only 2.7 centimeters. They have numerous other ongoing trials and more data to come, but that's basically their pilot. So to conclude, there are many atherectomy devices on the market for use in the tibial vessels right now. Each of them have their own strengths and weaknesses. The laser, very effective in soft plaque. It's very easy to use from tibial access sheathless. It's a very low cost device, but not so effective in calcium, so that would be its weak point. The Silverhawk has devices effective and good in both hard and soft plaque, not good for thrombosy lesions. Diamondback 360, very effective in severe calcified lesions, especially below the knee, not good in thrombus. The Jetstream has utility in both hard and soft plaque, and seems to me to be a little bit better when you have a lot of thrombus. I thank you for your attention. Be happy to answer any questions, and I'd like to thank Dr. Golzar for the invitation to speak.
Okay, thanks, Lou. I believe Dr. Goodwin is not here right now, so I think we're going to try and go back to Tom and see if we can finish up his case. Can we go back? There we go. Tom, can you hear us?
I can hear you loud and clear. How you guys doing?
We're great. We see you.
Well, can you see the angiogram?
No, right now we're seeing.
Can you get the?
There we go.
Can you see? Okay. Well, what we did was so far, we actually crossed that total occlusion just with using a wire. I know that's unusual for me, but we were able to actually get that wire, as you can see, coming down here, and we can get it. We were able to loop it all the way up into a communicating vessel. It looks like in the posterior tibial. I was only able to get it up to that wire only sort of mid-cap, because from where we're at, we're not antegrade, we're contralateral approach, so I didn't have enough catheter to go down there. So I'm hopefully going to do is just at least get enough down there to get that. So what we did was we took a SXC Turbo Silverhawk and then put a balloon down there, and we put a Angiosculpt 2.5 balloon 100 and went up and down here a little bit. And I'm going to finally give you some pictures to see what we got.
What type of wire did you use to get across that?
You know what? I just used a gold tip glide and I just looped it and went that direction. I was trying to get it done quickly so I could, when I came back, I was done. So let me get a digital. So we just used a loop wire with a gold tip, and it actually wasn't that hard to get by. And there's that. It looks like there's a spot right in that midsection right there that's going to be difficult to bring down another atherectomy device and just hit that again. We'll see what we got here now. Yeah, I think right there we're still totally occluded, so I think we're going to have to bring our atherectomy device down there, maybe do a lot of cutting, because we ballooned there a couple times and it really hasn't touched it, and that was a tough. That's right where the total occlusion started off. So
that was the cap of the occlusion.
That was the cap of the occlusion, exactly. Can I get an SXC? So we're just going to bring an SXC down there again, and we're going to try to cut that a little bit and see if that'll soften up. Because even with our scoring balloons, I didn't do long inflations, but we did about a minute each coming up there just to try to get done and get back here. But I think the key is, I think you can see we got the wire all the way down, looped around into the posterior tibial. So what I'm hoping is if we can get flow all the way down there, obviously we want to get those plantar vessels for this flap to heal better, for the transmetatarsal. So I think ideally that's what we want. Even if we can't, if that doesn't work, then what we can do is come antegrade, obviously, and come down the anterior tibial, and we know we have a communication. Yeah, just take this out. We know having the communication, so maybe we might be able to wire from coming back upwards and actually find the origin of that posterior tibia, because as you recall...
Tom, what size and what type of balloon did you use here?
I used a 2.5 Angiosculpt 100. Because you know what, after I atherectomized, I didn't get all the way down, couldn't reach down to the pedal arch with the atherectomy initially. So what I did was I wanted to use a scoring balloon down there, because I think they work actually pretty good down in these tibial vessels from what I've seen. So just from personal knowledge from it, at least. I don't know how you guys feel about the scoring balloons in the infrapopliteal vessels, but my feeling is they work pretty good down there. But
yeah, I like them. I like them down there as well. I think there's two possibilities. One is either the proximal cap still has a significant amount of residual, and I think the atherectomy in there will potentially help that. Also, your outflow may be a problem as well. You may want to dilate all around that arch with a 2.5 regular balloon, not an angioscore. I don't know if you'll be able to get an angioscore around that arch.
I couldn't get the angioscore down there. I'm trying to find out where that proximal portion is. Yeah. I couldn't get the angioscore all the way down there. So what I actually have is a Cook 170 shaft balloon just in case. I think the balloon's only going to go just to the communicating vessel. I think we already got the atherectomy device in there.
Yeah, there are some rapid exchange balloons now that have 200 centimeter shafts that will go all the way around there and halfway up the leg. So they're pretty nice for that kind of application.
Yeah, exactly. Unfortunately, I don't have. What I have is the Cook 170 shaft, and so I'll bring that down there and see what we get. I'm not sure exactly where that cap was, but yeah. I'm just going to go a couple passes down here. Go ahead. Nice and slow. Keep going. Push, push. So we're going to go. There you go. Go on further. Keep pushing. Keep pushing. So we'll see if we can. I think we've hit that cap already. I'll go beyond it just a little bit just to see if we can get a little bit more down here. And that's about the reach of it. And that's probably about where we had to get to. So you got that? Got the wire? So we'll take this out, we'll take a picture here now, see if we got anything.
For those in the audience that don't use atherectomy much below the knee, or especially directional atherectomy, you do need to be careful because the veins run very, very close to the arteries below the knee, and overcutting can lead to AV fistula and perforation there.
Yep, exactly.
Tom, do you have like a 2.5 by 300 millimeter balloon or anything that you can run all the way around the pedal arch up the posterior tibial artery?
Yeah, that's I think I'm going to end up doing, because I think we're just going to have to do a long inflation down here. We have, there was a spot in the pedal arch that we were in. I can show you what we did get a picture down here. Why don't you give me a Vascutrac 2.5 by 300. I think I got a picture down here somewhere. Let me just take a look at it and see. Before we ballooned, we just took a quick picture down there, and I'll show it to you here after we got down.
Jaafer, you brought up a good point, which is, while Tom's working, I'm just going to promote a little discussion here. If you do enough of this work, you're going to perf one of these vessels, you're going to create an AV fistula. I have done so many cases where I did one pass with the atherectomy device and confound it, get a AV fistula or a perf. And so I think we need to discuss how do you deal with that? So my first thing I do is if you've made a single pass, you recognize it right away. Sometimes wait 5 minutes and it's gone. But if you wait or if it's a robust perf or AV fistula, I think the first thing to do is take a balloon down there and inflate it for a prolonged period of time and try and get rid of that. But I think everybody should. I would like everybody to comment on how they deal with these issues.
Yeah. So this was the picture after we went through the total occlusion and took a picture down there, and you can see it's kind of just. There's a vessel down there. As you can see.
Tom, there was one image that on your pre-shots right after you did the popliteal Silverhawk that looked like the dorsalis pedis terminated right before the TMA. And I think that if you dilate around that pedal arch, you're going to have better outflow. It's going to flow through there a lot better.
I think you can see it right there, on this picture.
Yeah, I agree.
Here. Before, just at the early portion of the image, I think you're right. I think it's a short reel. I think you're exactly right, Eric. I'm going to have to come down there and I think maybe just a long inflation and with the balloon.
I'll tell you what, we're gonna go and do another lecture or two, and then we'll come back to you in a few minutes. How's that sound?
Okay, that sounds great.
All right, we'll see you in a bit. Thanks. Yeah, so we're going to go to Sonia Noor is going to talk to us about tibial bypass for CLI. It's not often you get two talks in the same session.
And a surgical talk at that. So we're going to talk a little bit about tibial bypass in critical limb ischemia. We refer to this as the gold standard because the results of bypass are so good, but honestly, a contemporary trained surgeon, vascular interventionalist, anyone who does peripheral work, the first line of therapy has become endovascular therapy, and I think that's very well accepted, definitely amongst the younger interventionalists, and by that I mean vascular surgeons, interventional radiologists, interventional cardiologists who do peripheral work. But it's a good art form. It's something that we still need to learn how to do. We looked at our bypass numbers. I probably do 3 tibial bypasses a year now, which the problem with that is we're not able to train our fellows and residents how to do tibial bypasses. So when I need a tibial bypass, not too many people are going to know how to do it. So that's a problem. So really to get down to the nuts and bolts and to simplify the various conduits and different configurations you can have is there's a blockage in the artery, very simply speaking. We're talking about below-knee bypasses, so most of it almost always includes part of the SFA, part of the POP, and then you're bypassing down to the tibial vessels. And you need a bypass graft that's going to connect the dots. So sometimes it starts at the external iliac artery or the common femoral artery or the profunda or the SFA. In the previous life case, you heard about how the POP bypass went down, which means it was above knee to a below knee popliteal bypass. The problem with that bypass was the patient didn't have adequate runoff to support the bypass, and therefore the bypass failed. So that's a lot of hard work for nothing. So the choice of conduit very much determines how this bypass is going to work. And this is where vascular surgeons and cardiac surgeons hate each other, because it's a matter of who's going to get to the vein first. And you want to have a good piece of greater saphenous vein. And the bypass is determined not really so much by your inflow and outflow, but of the quality of the vein and not injuring the vein when you harvest it. So the greater saphenous vein is the conduit of choice. If you're going to do a long bypass, like a common femoral or an external iliac to a distal bypass, you want a long segment of vein. And you want to be able to harvest it without injuring the vessel. So greater saphenous vein is obviously your vein of choice. You can go contralateral if necessary. Most of these patients also have peripheral arterial disease, so you may not have a healthy contralateral limb to be able to do a leg vein harvest from. Older literature has talked about taking out the superficial femoral vein, which is a deep venous system vein. That has been published. It's not really commonly done anymore. So the next default would be greater saphenous vein, short saphenous vein, or smaller saphenous vein, and then the arm veins. There's literature reports about an endarterectomized segment of the SFA. Again, that's not something that's commonly done anymore. There's cryopreserved vein, and occasionally the radial artery can be used. Again, we fight with the cardiac surgeons about that, but you can use a part of the radial artery to do a short bypass. So the concept of the bypass is you have to have your inflow dissected out, you have to have your outflow dissected out, and in this particular case, it's an above knee to below knee bypass for trauma. I just use this as a picture just to give you an idea of, it's not just the proximal and distal dissection, now you have to dig out the vein. And really, that's what the patients complain about, the morbidity of the vein harvest rather than the bypass itself. So this is how you have to harvest the vein in order to do the bypass. So the preferred conduit, like we talked about, is the greater saphenous vein. You want to have one piece of healthy vein. If it's unavailable, we'll go for the small saphenous vein or short saphenous vein, and for a shorter bypass. So there are two ways to do a bypass. The column on the left is the reverse saphenous vein graft, which is important to understand the concept because you're taking a large greater saphenous vein, you're flipping it because the flow direction, as you recall, in the vein is in the opposite direction. So you're putting the common femoral end onto the tibial artery, which is half the size of it, and you're putting the distal end, which is the small end, onto the inflow part of the common femoral artery. And that's been an Achilles heel for bypass surgery, but that's the standard way to do it, the reverse saphenous vein graft. The guys in Albany in the late 70s, early 80s really started doing in situ bypasses. And so when you look at the old op note or you're trying to figure out what the difference between a reverse saphenous vein graft and an in situ is, basically you're dissecting the vein out alongside the artery. You're taking the small side of the vein, which is where the tibial artery is, anastomosing that. So it's a much better match between the distal end of the greater saphenous vein with your tibial artery, and the common femoral artery gets anastomosed to the large part of the vein. So it's a better vein match. The problem is the incisions that you have to make in order to keep the vein in its natural bed. So it's a subcutaneous bypass, essentially. So when the wound is all healed, it's good, but until that wound is healed, you're talking about a very superficial vein bypass right underneath the skin. When you look at the numbers, there's an advantage to doing reverse vein grafts in the above knee population. When you look at below knee, because of the size mismatch I talked about, in situ vein grafts actually do better. And this is a busy slide, but that's the take-home point from this, is that in situ does better in below knee and even ankle or inframalleolar bypasses. What it's most dependent on, whether it's an above knee bypass or a below knee bypass, is the vein size, and it has to be larger than 3 millimeters to be successful. So if there's no greater saphenous vein, no lesser saphenous vein, our next fallback is arm veins. And people have tried to come up with ways to get longer segments of vein, because otherwise you have to what's called splicing it together. You take a part of the cephalic, part of the basilic, sew it together, and then make a long bypass because there's no leg vein. Newer techniques have been developed where you try to get the basilic vein, the median cubital vein, and then hook it up, going up to the cephalic vein, so you get a long segment of healthy vein. If that's not an option, as I said, the literature has referred to the deep femoral veins. That's really no longer used. And then for a short segment bypass, more for trauma than anything else, a radial artery could be used. So that comes to prosthetics. So if you don't have a vein, or you're unable to use a vein because of an ischemic leg on the contralateral side, what do you do? And really, this is probably more bypasses are done now with prosthetic because of the improvements that have happened. So the prosthetics that are available are Dacron, heparin-bonded Dacron, human umbilical vein, not really used as much, PTFE, or more importantly, PTFE, and then heparin-bonded ePTFE. Just a blurb about cryopreserved vein graft. This is somebody else's vein that's been frozen, and then you can use it has to be typed and crossed. It has to be ordered in advance. It's a good conduit for an infected tissue. It's not as good as autologous vein. It's not as good as prosthetic even. But if it's a very badly infected wound and you don't have your own vein, then cryopreserved vein is an option. So in the prosthetic grafts, when we look at PTFE, that's probably been revised the most, even more than heparin-bonded Dacron. There are multiple studies that have tried to compare, is Dacron better than PTFE? And there's really no good consensus, but a lot more changes have been made on the ePTFE side with heparin bonding and different configurations of the hood, etc. So most people, if they're going to use prosthetic, they've been using heparin-bonded ePTFE, both above knee and below knee if there's no vein. This is a modification made of the PTFE, and that's by adding a vein cuff. And the reason is that's where the bypass goes down. There's such a big intimal hypoplastic reaction at the bypass site that by adding a vein cuff, like a Miller cuff or a Dister Taylor patch or a St. Mary's boot, there are a few studies that look and see if the bypass durability improves. And really, the bypass durability did not improve. Limb salvage went up a little bit. So it's questionable whether this really makes a big difference or not. Of the heparin-bonded ePTFE, there's multiple studies out there that looked at if the heparin actually helped, how long did the heparin stay in the circulation, did the platelet activation and fibrin deposition below. There's really no good proof. In animal studies it did. In patients it's not seen. There are 5 or 6 large reports, and a summary of that is they're not randomized. They don't have control groups to compare against. There's a selection bias, so there's really no clear idea that the ePTFE heparin-bonded graft is as good as vein. In the prosthetic grafts, obviously the heparin bonding helps. This is a large series of 356 grafts where they looked at above knee and below knee. Some went to the femorocrural or the tibial, and it wasn't quite sure what the target was, like it was an intermediate area. Again, the data and the follow-up was not good enough to compare against other prosthetic grafts. Definitely it's inferior to vein, and when you don't have vein, really there is no choice but to have to use it. And more randomized trials and larger trials would be a good way to follow these. Changing the hood and allowing more laminar flow at the distal anastomosis is something that the companies are working on to see if that makes a difference in terms of less intimal hypoplastic reaction at the anastomosis. So in terms of patency, again, this is a busy slide, but what I wanted to show you is if you followed it out for 4 years and you looked at reverse saphenous vein graft versus in situ, they both are similar long-term. If you looked at secondary patency, again, both of them are similar. Human umbilical vein drops way down to 31% or 37%, and PTFE is down to 20%. So long-term prosthetics do not work as well as venous conduits do. In terms of limb salvage, obviously the vein works the best. PTFE does have a role, and year 2, 3, and 4, it's in about the 50% range, which is what we're trying to do mostly for these patients is limb salvage. It's important to follow with duplex surveillance. A lot of the old-timers who did these long cases often didn't follow it, but I think those of us now who do these endovascular interventions, just because the patient had a bypass does not mean the patient can't have any further procedures done. It's a good technique to be able to follow a patient who's had a bypass, do duplex surveillance at 6-month or yearly intervals, not wait until the symptoms come back, and then if there is a lesion, it can be approached endovascularly. If you look at vein grafts in terms of where it was done, the longer the vein graft, usually the worse the performance, but vein grafts have worked well in ankle or even inframalleolar bypasses. It can last up to 2 to 3 years, but I think it lasts 2 to 3 years because with duplex surveillance, there's secondary interventions that are done, which allows limb salvage. And as you can see at the 3-year, it's anywhere between 76 and 84%, 76 and 72%, and the foot salvage was 84%, which is what we want. We want foot salvage. So in summary, your saphenous vein graft is your first choice. The shorter bypasses obviously work better than the really, really long bypasses. In the prosthetic realm, EPTFE with heparin bonding, definitely the performance is improving. There are no randomized controlled studies to say that for a fact. But the more and more we do these procedures, clearly these patients, a below knee bypass with heparin bonded PTFE may not need long-term anticoagulation. Anything below the popliteal artery into the tibials, for example, if you use prosthetic, almost always those patients need to have some form of long-term anticoagulation. Again, thank you, Jaafer, for the invitation. It's been a real pleasure.
Okay, our next speaker is Janelle Jenkins, who's going to talk about the post-revascularization care of patients.
Good afternoon. I want to thank Dr. Golzar for the wisdom of putting this together, and this is our 5th year here, and I want to thank everybody for coming. One of the things I'm going to talk about is after the revascularization of an ischemic digit. And the main thing that you must remember is that we have to go back to the drawing board the same as before the revasc. Is it this one?
Push the green button.
Okay. Oh. The causes of digital ischemia include severe obstructive arterial flow caused by ultimately digital necrosis, chronic conditions, long-standing PAD, hypertension, hypercholesterol, smoking, diabetes, and I think in Chicago now we have to add gunshot wound, and end-stage renal disease is one of them, and also IV drug use can also be a cause of PAD. Then you can have an acute addition of an embolism or a thrombosis, and then of course some of the more chronic conditions like Berger's and even Raynaud's. You have to really, really, really listen to your patient. You have to go through a complete history and physical. Nobody is going to come in your office and say, oh, doc, I think I have poor circulation. I think my SFA is occluded. Nobody is going to say that. But you really have to listen. We had a patient that I think I had with Dr. Golzar. She had perfectly good pulses. Toe was just a little bit dusky, and she just kept telling me that she couldn't sleep well at night. And one thing led to another, and I said, you know what, I better check out her circulation. And sure enough, she had an occlusion that Dr. Golzar fixed, and she thinks he's the best thing since cream cheese. But you really do have to listen to your patient. Pain at rest is one of the main things, and this is one of the things even before or after the revasc, you have to still listen to make sure that the problem has been taken care of adequately, and if you have to do any other adjunct therapy. Some of the things they also present with is spotty necrosis, which they really don't think is necrosis. They think it might be a little dark spot on the end of their toe. Dr. Harkless spoke earlier this morning about an ingrown toenail. A lot of them come to a podiatrist's office complaining of an ingrown toenail. You really don't see an ingrown toenail, but you do see a bluish discolored toe, and that's what they thought was an ingrown toenail, and you take it from there for some type of revasc, or you work the patient up appropriately. Like I was saying, the dark and discolored, the dusky skin, skin cool to the touch. I'm just going through these. I know all of us already know these, but this is actually the basics of wound care. We just always have to go through the basics of wound care. You can work, do some blood work in your office. You can do a handheld Doppler. These are all tools that we should have in our offices to kind of rule out some of the bigger problems. And you can also have, you can do an ABI. You can, some of the figures that they've always thrown around about ABIs is under 0.4 or under 0.65 for no surgical intervention. Of course, we know normal is 1 to 1.3, and a calcified vessel can be 1.4 and above, which means that they do have something like mockingbird sclerosis or some other calcified situation. A lot of times on radiographs, we'll see the calcified arteries, and it's something that have to be dealt with. Then we go into the toe brachial index with calculation of the BP of the arm and the toes. These are some of the things that they don't do as much as they used to, because they used to do plethysmography, but I think Medicare stopped paying for it, so a lot of people stopped doing it. But I think that was one of the key ways for digital necrosis. Okay, for the treatment, this is my good luck with that slide. Smoking cessation, blood pressure control. Your patients are not going to stop smoking. Your patients are not going to lose weight. Your patients are not going to stop eating fried chicken. Your patients are not going to stop doing anything. So this is what I call the good luck with that slide, so good luck with that. Of course, the medications, we can augment them with Platel for before and after the revasc, and then also Trental. Surgical interventions for of course, is revascular, and then we talked about the bypasses earlier. And of course, when after the revasc, we're faced with whether or not we have to deal with the wound situation, which usually we do. And a wound after a revascularization is very, very challenging. You'll have either a foot ulcer, you have a gangrenous process going on, and you have to actually go to the drawing board and figure out what is going to work with this patient. So you evaluate the blood flow, you find out exactly where the flow stops. And it's critical then for an amputation level, because the vascular surgeon has done all that they can do. They tell you where the circulation stops, and then you have to take it from there. Too distal, of course, increases the chances of further necrosis and amputation morbidity. In other words, you have to keep chopping until you're chasing a problem, and then it actually gets worse. And of course, the main goal after the revasc is to restore function, mobility, and the quality of a patient's life. Now, these are some of the tests that we do. We talked about the ABI, we talked about the toe pressure. Now, transcutaneous oxygen tension, that is a very good test. A lot of people don't use it as much as they should, but we'll talk a little bit about that along with the laser Doppler, the lunafluorescent, and let me keep going here because they got my timer going. So the transcutaneous oxygen tension, that is a very good test. You usually put a probe around the knee, around the thigh, and around the ankle, and certain spots in the foot, and you watch the degradation of the millimeters of mercury. Usually it starts at 55, goes down to 30, 20, and then further down in the foot. Usually when it's 20 or higher, it shows you a good accuracy for 80% of healing in the site of that particular spot for amputation. The difference in values is indicative of course, ulcer sites. Now, this is a transcutaneous, these are how the probes look on a foot, but it's always, when you've been doing wound care and foot care for a long time like myself, you can easily just walk in the room and kind of tell where this person is going to heal and where they're not going to heal. But your eyesight is not good medico-legally, so you always need something to back you up and say, oh, well, Mr. Your Honor, I did do this, I did do that, and, you know, something to back you up. But you can tell the skin on this foot is not good. The transcutaneous oxygen level, I think, was 20 at the site of the probes, so therefore they ended up with a transmed amputation. Now, this is another machine. It's a laser Doppler skin perfusion pressure. And these machines are, it's mainly a Doppler machine that has a laser guide on it. They are bulky, and a lot of people don't use them. You use a cuff. You actually calculate the pressures in a foot, and you can actually use your own software, and you can have an optic probe on it. And this is what they look at. They're kind of bulky, and a lot of people don't go through that. Now, this lunafluorescence angiography, these are actually wonderful, wonderful machines. The patient's foot lights up, and it actually will tell you where the flow is and where the flow is not, and where the amputation site should be. The only thing bad about these machines, they're extremely expensive. They run about $250,000. Good luck with that. And they're very high tech. They're easy to use. It actually illuminates the vasculature of the foot, and it is a very good indication of what's going on. Of course, the MRI is something that we do use in the hospital, and one thing good about the MRI, it will tell you exactly what kind of osteomyelitic processes you have going on, and we use the MRI a lot after a questionable radiograph. Usually when the radiograph is clean, we don't have to worry about osteomyelitis, and then we can go further. Local wound care, I'm not going to bore you with that, and I don't have time for that, but essentially offloading, aggressive debridement, always debride anything that's necrotic or dead, clean it off, and add some kind of wound care product. I think they're going to talk about that tomorrow. Remember, no two wounds are the same, and these wound care patients are patients for life. Now, this is a couple of patients that I can show you. This young lady here, she was revased. Chronic smoker, 2 packs a day. She was revased at Mercy by Dr. Jones. This was the front of her foot. And of course, they come in with blister formations, and the blister formations, once you bust the blister, the skin underneath there is raw, and this is how the bottom looks. So I knew that those toes were gone. And this is after the revasc. At least it was dried up gangrene after the revasc. But then we knew at this point that we had to do and then you let it, we had to do a TMA. So that's the TMA we did. Here's another patient. This is IV drug user. This is a perfect example that don't let a patient talk you into anything. And I knew when I saw this patient that was going to have to do a TMA, but she cried and said, "Oh, doc, just take off the end of my toe. Just take off the end of this toe," because she did have circulation going up into the toe, but her skin was not good. And you can actually see here where it's demarcating. And of course, as soon as we took the stitches out, it opened up and it went on to, and then I would have went right on and done the transmet, but she refused. She cried, so I just had to keep on until she was sick of looking at it and it was smelling. And so this is when it started gangrenous smell, and then we had to go on and do a TMA. And I think I got one more here. This is a gentleman that actually belongs to my associate. Dr. Dewar, how old is this patient? I don't know how old this patient is, but I don't think he's here. But anyway, this is how he presented. And you can see at the top of the second toe is still a little bit viable, but you can tell that fifth toe is having issues. And of course, he had circulatory problems and he was revasc. And after the revasc, the fifth toe was amputated, and the second toe actually went on to do pretty well, because you can actually get CFT. Anytime you get CFT in a toe, usually you're doing all fine. Okay, this is my baby. Reason why I put him here, the moral of the story with him is I think we should all have been veterinarians. He has heart condition. He's on enalapril and furosemide. I took him they have a cardiac veterinary doctor, and for $1,200, he did an echocardiogram. And he didn't ask me if the dog had Medicare or Blue Cross. All he did was ask me how was I going to pay. Thank you very much.
Thank you.
All right, Tom, we're back for a few minutes, then we're going to cut to our break. Where are you at? Tom, can you hear us?
We actually dilated all the way around, and I'll show you what we got here. What happened was we went all the way around, and we got down in the foot, and everything looked good, but I wasn't getting any flow down there. So I took a catheter down there and just started injecting down distally and see what we had. And it wasn't going anywhere. It was staying there. The vessel was open when I pulled all the way back. So I don't have a picture of that, unfortunately. But so I put the catheter down the foot. The vessel was wide open. My wire was flying down through it. Let's see here, I went too far back. Anyways, I wasn't, the flow was just poor, and so I all of a sudden wondered if my inflow was a problem, and guess what? So that is the problem. So I'm going to have to balloon this. I'm going to put a balloon up here and just dilate this up, and hopefully that's going to solve, because the vessel's open. When I inject from just using an O1A catheter all the way up and down, it fills, but it fills very, very, it's just sluggish all the way, and doesn't really empty very well. So I think this is my whole problem. I think, we just need to balloon this up a little bit, hopefully, and see what we got. And if not, we may end up just putting a stent in there if we have to. But we'll try seeing what a balloon does to it.
It seems like the proximal cap of these is very frequently the culprit, and this is where they typically will close. And I think that the proximal cap always seems to deserve a lot more attention than the rest of the occlusion, and I have a very low threshold to put short stents, even a 2-centimeter stent right there just to prop that open, and then the remainder of the artery will flow fine.
Yeah, I agree. This is complicated. It's worse than just the proximal cap. This is an area of stricture where they had a prior bypass. and that's even harder to deal with.
Yeah.
So I think a short stint is very reasonable. It looked to me like he'd achieved very nice outflow, and I bet once he gets beyond this, this foot ought to light up very nicely.
Yeah.
Yeah, because I actually did have a good vessel. If I can get back to it, I'll try to show one of the pictures. We would take a little bit. We actually did have flow all the way down there.
Come on up.
You can see a little bit coming down and through here now, but I think it was one before this. A little bit. I'll try to find it for you here.
The only other thing to think about, just from a procedural standpoint, is what's your anticoagulation? Are you using heparin? And what's your ACT at?
Yeah, we're using heparin, and we just checked our ACT not too long ago. It was 260. So you can see here's what we had after I ballooned up and down all the way.
Yeah, that's going to look fine once you get some inflow.
Yeah, this is inflow.
Yeah, and then a couple shots, and then after that, I was pretty proud of this. I was going to come. I was waiting for you guys to come back, and then all of a sudden there's nothing down there.
Hey, Tom. Tom, can you hear me? This is Amir. I'm here to solve your problem. You are not dealing with popliteal artery. You're dealing with your graft. This is an end-to-end vein graft. And so what you have to do, put a piece of Viabon through that and call it off.
You know what? That was probably my next option if this doesn't look good here. I think you're right. I'm not actually in the graft. The end-to-end graft is closed. You could see the origin of the the graft when I first took my pictures. Were you thinking it's in the graft itself, or?
I don't think so.
Amir?
Yes.
You think I'm in the graft?
They're having an internal discussion here on the panel is. So why don't you share with us what your discussion is, guys?
So Tommy, Amir thinks that what you have is an interposition graft. In other words, the straight line flow is through a saphenous vein bypass graft, and Eric thinks that there was a graft that went around the area of occlusion, so that's the controversy that we're having on stage.
Yeah, I think it went around too. I think we saw that on the first picture.
We are in the popliteal because you could tell it wasn't a graft when I went through with the ultrasound. It was not a graft. We're not in the graft. We're in the popliteal artery. You could see that on the ultrasound when we did it. Remember?
Amir, you didn't see when he crossed. He crossed this using optical coherence tomography, and he actually saw plaque throughout this entirety of this. So I'm pretty certain he is in the popliteal artery.
And in the OCT, we saw clear layers.
The nub of the graft, you could see that it was out. So it's not the graft. It's not in the graft. You could see the nub.
Just going to see if we got an open vessel here now. Yeah, but it was clearly in the. I'm clearly in the popliteal vessel. I'm not. I'm just going to do a little puff around here. So I think this is better. Now let's see what we got at the foot. I want to see just see if we got any flow down the foot now that we got that opened up. And we still don't. So there goes my idea on that one, huh, guys? Let's see here.
Tom, what I would do is I would put a short stent in that popliteal segment right at that distal, at that proximal cap. And the other area that you may need to stent is the very proximal cap of that anterior tibial artery. And I use short, like a drug-eluting stent, a coronary drug-eluting stent right there, and prop that area open as well.
Yeah, you can see it's just not coming down through there. You know what I'd like to do, because I'm just not 100% certain where to put that stent down there. What I'm going to do is I'm just going to take this down, the balloon down here. Take the balloon down again. What I'm going to do is I'm just going to inject through the balloon down there and see if I can see if there's a stenosis down there.
Eric, you brought up a good point earlier, which is anytime if you're doing an intervention, you see the flow starting to slow down. First thing I always do is check an ACT, Then I give a little extra heparin, and many a time I won't give an infusion, but I'll give a couple boluses of integralin right down the vessel and some IV nitro, and a lot of times that makes things a lot quicker within about 5 or 10 minutes.
Yeah, that's a great point. In this case, though, that's not going to be what's going to make the difference because you have outflow. When it's a vein, when you've got a lot of clot, the outflow sort of goes away. I think what this is an inflow phenomenon. When he injects beyond the inflow issues, everything lights up, and then it clears. So I really think here, if he can prop open that one spot, he could do it. Now, he could absolutely show us that in another way. If he went with an 035-based balloon and put it up over this 014 wire, connected a 2-way to the back, while he's inflating, take an injection, it would show if everything's patent or not, and then you would know. And then that would also give you a good idea where to stent.
One of the things I use for this also is all of the aspiration catheters, like the export and so forth. I use those probably 10 times more for angiography than I do for aspiration. They work great to inject through.
That's a pretty expensive piece of catheters.
Tom, obviously this is a very, very difficult case and very challenging case and kind of goes to the caliber of the kind of work you're doing over there. We're going to go ahead and break right now. Why don't you just summarize and just let us know what you're going to do from here, and maybe we can come back after our break.
Well, I think that idea where that proximal cap and that tibia, you can see right there where the, this is an injection into the tibia, and you can see right there where I'm having that problem. So that's how I am going to put a stent there. That's the mid-tibial vessel right there. I think you can see it pretty well.
Tom, before we, after the case is over, do me a favor. Get hold of that surgical report, please.
We'll come back to you after our break, Tom. Thank you so much. Hopefully you'll have some angiograms, and thanks for doing this case for us.
Give me a 3-0 by 23 drug eluting.